Good morning, everyone. I'd like to welcome you to this public meeting on behalf of the National Academy of Sciences, Engineering, and Medicine. I'm Dr. Alex Christ, and my colleague, Dr. Jeanette Southpaw, are co-chairs of this ad hoc committee on transforming healthcare to create whole health strategies to assess, scale, and spread the whole person approach to health. I want to start by recognizing our fellow committee members who volunteered for this study. We have Andrew Bazemore, Tammy Chang, Margaret Chesney, Deborah Cohen, Seiji Hayashi, Felicia Hill-Briggs, Shauna Hudson, Carlos Hain, Chris Kohler, Harold Cudler, Sandy Leake, Patricia Lillis, Ajuz Ninin, Pam Schweitzer, Sarah Singer, and Zuri Song. So thank you all for volunteering for this committee and this important work that we're doing here today. I'd also like to acknowledge the study staff, Mark Mesnier, who's serving as the study director, Cheryl Nass, who's the director of the Board of Health Care Services, Marjani Cephas, and Tochi Ogbu Begdui. I'm very sorry. I know I said that very wrong, and I need to practice that. I'm sorry, Tochi. All of you are amazingly helpful for this study, and we can't do this work without you. We'd also like to thank our study sponsors whose generous support has made this important work possible: the Department of Veteran Affairs, the Samueli Foundation, and the Whole Health Institute. So thank you all as well. This meeting is the committee's second open session. Over the course of the study, the committee will examine the whole health approach to healthcare and recommend future directions and priorities for scaling a whole health system of care at the Department of Veterans Affairs and in other settings caring for veterans. More information about the scope of tasks can be found on the handout sheet on the project website. I'd also like to give some sense of the format of today's meeting. We're going to hear from 4 speakers today on different whole health person approaches. We've allotted 30 minutes each for our speakers, which can include some time for questions and answers. I think we're going to be a little ahead of schedule on the welcome and introductions, which will give the committee some time for our discussions. And we've also allotted additional time at the end for questions, followed by a brief public comment period. And we'll take a break in the middle for lunch. We've tried to schedule this so that it accommodates both our East Coast and West Coast committee members. And interested members of the public have registered to attend this meeting as observers. While we've designated a few minutes at the end for public comments, this is not a news conference. If there are reporters in attendance who'd like to talk with study staff or members of the committee, please email wholepersonalhealth@nas.edu. The public can also send written comments to the committee via email to the same email address. We really want to hear what people have to say about the statement of task and the work that we're doing. That's very important for our final recommendations and report. I'm trying to see here, Mark, do we know if, Jeanette, do you want to jump in with the next section, or you want me to?
Absolutely. That sounds terrific. Thanks so much, Alex. I want to note that this is an open, on the record information gathering session. That is, the committee is in the process of assembling materials for the study that it will examine and discuss in the course of making its findings, conclusions, and recommendations. Therefore, I ask everyone here today to be extremely mindful of the fact that the committee has made no conclusions, and that it would be a mistake for anyone to leave here today thinking otherwise. Comments made by individuals, including members of the committee, should not be interpreted as positions of the committee or of the national academies. In addition, committee members may ask probing questions that may not be indicative of their personal views. Can you all hear me? Yeah, great. The committee will deliberate thoroughly before writing its draft report. Moreover, once the draft report is written, it must go through a rigorous review by experts who are anonymous to the committee. The committee then must report to this review with appropriate revisions that adequately satisfy the National Academy's Report Review Committee and the NAS President before it is considered an official National Academy's report. The committee's report is expected to be issued at the end of 2022. Now, I'd like to turn the meeting over to our first speaker for today. What I encourage you to look at the National Academy's Whole Health Open Agenda today for the speaker bios so that you can get more detail about each of our speakers. But in the effort to really maximize our time, I will just say that our next speaker is Dr. Ursula Kelly, a tenured associate professor at the Emory University Woodruff School of Nursing and a nurse scientist at the Atlanta VA. Welcome, Dr. Kelly, and we're so excited to have you here this morning. While Dr. Kelly is trying to get her screens to work, I just wanted to say that we're excited that her areas of interest. Her research has focused on violence against women, specifically the mental and physical health effects, barriers and facilitators to disclosure and treatment seeking relationships to intimate partner violence. So she's come up with some innovative models, treatment models for the psychological effects of interpersonal trauma. And we know that the work that she's done as a principal investigator on a VA HSRD funded study of trauma-sensitive yoga for women veterans with PTSD who've experienced military service trauma, sexual trauma, will be very valuable to us as we contemplate our discussion.
And so valuable if I could get the screen to maximize. I am so sorry. I may need to log out and come back in. I'll be as quick as I possibly can.
Sounds great. I do believe that we have some of your slides. Isn't that correct, Mark? And okay.
Nope, but I will send them right now.
That might be helpful so that we can actually display them on our own platform.
I think I'm.
And to buy some time as you're doing this, Ursula, just to kind of orient for this open session. So from 11 to 11:30, we'll be hearing from Ursula with the trauma-sensitive yoga for female veterans. 11:30 to 12 per the agenda, we'll be hearing spiritual care and whole person from Captain Bob Evans, who's on here. And then 12:50 to 1:20, we'll hear about what is within you is stronger than what is in your way from Gretchen Evans. And 1:20 to 1:50, the South Central Foundation for the NUCA System of Care and Overview. So that's kind of an oversight of what we're going to see for the next session. And Captain Evans, maybe if we have lots of troubles, maybe we'll flip-flop your talk with Ursula's if we need to.
Understand all. Ready?
Why don't you go ahead and do that? I feel terribly about the delay, and it looks like I'm going to need to reboot my computer. So, Robert, I do not want to miss a moment of your talk, but I am going to log off and reboot everything, and I'll be right back with you all. So why don't you flip?
Nothing so you probably haven't heard already, Ursula, so don't worry.
Well, we're excited then to go ahead and welcome Captain Bob Evans, who's a tenured associate professor at Emory. Who's a graduate of Bowdoin and Princeton Theological Seminary and the Naval War College, and has had an amazing career as a senior leader for the commander of Naval Fleet Forces, but has also commenced his career at the VA in 2011 and recently retired. He's a devoted advocate, and we look forward to hearing your comments, Captain Evans.
Well, thank you. And I'm not a tenured professor. I am a very happily retired healthcare worker and board certified chaplain. I would like you to stop, look, and listen. The reason why I use those words is, if you remember as a child, what were you first told when you came to an intersection in your life, or you came to a street corner or to a side of the road? You were reminded to stop, look, and listen. For me, those are key words in providing healthcare in general, because they remind me that unlike my experience the past 2 weeks in a VA medical center where a ultrasound tech started through the procedure and talked nothing about me or asked any questions about me, but proceeded to talk about her daughter who would not get her COVID tests. It turned around that I was able to then unpack with her some of her frustration, some of her trauma, and some of the issues that were entering into her life. Unexpected, but still, because I stopped, I listened, I looked at her whole demeanor and saw that she was anxious and upset and couldn't really deliver the best of healthcare. I then assisted her in getting back on track. Similarly, in the ED, just a week before, I proceeded in with my issue, and the doctor started to talk about his military career. Didn't look at my chart, didn't know that I had any problems with or past problems with cancer or the like. Yes, I am a cancer survivor, and I'm thankful for the hands that took care of me and the doctor who saw me and heard me and spent time with me through that process, companioned me through the process. But this doctor did not. And then just yesterday, I was up getting examined for a pre-surgical consult. And in that, I was greeted in the room and my name was called out loud and strong. And I was ushered back to an office. But during that journey, that short distance travel, the nurse spoke about the fact that he only had 328 days left in the VA. He was so tired, so upset, and he was rumpled in his appearance. When he brought me into the office, I kindly spoke to him about his issues. And again, I stopped the conversation. I listened to his story. And I asked him, do you have any passion, any sense of purpose, any hope for the future? Do you have something in mind as to what you'll do next? He had none. So I asked him again, what might he consider doing? And he then started to speak of several things. It was amazing the transformation that happened in that millisecond of time. But if you think about it, those simple actions of stopping, looking, and listening tell us how we are supposed to go about whole health care. We need to be intentional in the way in which we approach our people, intentional about their lives, their stories, what's going on with them, taking that millisecond of time to ask them about their day. You see, we've got to talk about the biosocial, psychological, spiritual spectrum, not just the spiritual. The spirit may be the core, and it may be much of the hidden story, but it's our job to surgically strike at every part of that person, every aspect. And I'm afraid that in my experience, it hasn't been very much the case where we take the time, yes, time, those 15-minute slots, those 40-minute slots, they just are not enough to develop the relationship required for the continuity of care and for the true caretaking of those individuals. And in the end, it's all about the relationship, isn't it, in healthcare and whole health? Because if you don't know their situation, you don't know their surroundings, you don't know their connections, you don't know their educational background, you don't know what resources they have, What do we have? How can we administer care to those people? If we have a tendency instead to treat the individual or treat their problem. I don't know whether you know this or not, but the word treat in the Greek means to drag through. And I don't think we want to drag people through their care in any way, shape, or form, or in dragging them, find that we injure them even more. So I guess what I really want to get to here is that we as caretakers and provision and providing care to our people need to pay more attention to those individuals who cross our paths. I would recommend that you treat them as if a gift. Now, each of us have our own way of unwrapping gifts that are given to us. But in the end, when we open it up and we take the lid off the box and we pull the tissue paper away, what do we see? There's some joy in the discovery, isn't there? And some of us lose the sense of joy in the discovery process. We go through each person's chart, maybe, but that's part of opening the present, is to look at the chart, study the chart, and know what people are presenting to us on that day. Yes, and we also need to collaborate with our nurses who are probably doing a lot of the preliminary work. But we need to know their stories. We need to understand where they're coming from, how they
Unfortunately,
actually
I'm in a meeting right now and can't leave.
So we need to take time to look at their chart. We need to take time to look at them as individuals. How do they present? Are they rumpled? Are they squared away? Are they in a positive aspect? Are they in a good mood? Are they in bad mood? Are they conversational or are they not? How do we evoke some of those, that information from our people when they come into the room? I found that many of my colleagues, not chaplains, but colleagues in our collaborations, nurses, doctors, techs, many of them take moments of meditation before they see any patient, each patient. And as a result, the atmosphere in the room is much, much more positive than it otherwise could be. The other way in which we can ensure that we have a good situation is, again, collaborating with all of those who touch this individual. Chaplains, it's been proven in evidence-based studies that chaplain collaboration with other healthcare functions provides at least a day or 2 days earlier departure from the hospital. We found that we have much more positive outcomes as a result of intervention by chaplains with mental health and with other aspects of the medical delivery system. We also end up with better patient satisfaction scores when chaplains are involved. So we really have to look at the collaboration between all and find out what our specific tasks are and what our linked tasks are. How do we leverage those so that we end up with a comprehensive care plan for our patients or our clients, whatever we're calling them today? It seems to change regularly. So all in all, I would say that the most important things for us to do is to work together, talk with one another, and make sure that we have a good conversation with each one of our patients when they're with us, before us, and be intentional in our approach, inclusive in our approach. Of course, very invitational to invite those people into the care plan with us. And then as a result, we'll have sensational, inspirational care delivered. And we'll see transformation occur with our clients. So I think that, again, all factors playing, we need to work together, we need to converse and have team meetings on a more regular basis about our various clients, and then discover together what is the best way ahead for them. But it is going back to the basics of seeing that person, hearing that person, attending to how they present to us and what their concerns are, what their fears are, where they hurt, what is perhaps hidden from us as well. Especially with moral injury today, many of our veterans and others have shifts within their person that need a special touch and a special care to bring that out and help them find a way back home again. That's all I have. Thank you very much.
Thanks so very much, Chaplain Evans. It's just the sense of peace that I know I feel as I listen to you introduce the way we approach each patient who comes to us. Produces a sense of calm, and for that I thank you. And I think it gives us an opportunity to see how to embed the spiritual aspect of caring for our patients and our colleagues in practice. So first question I would ask you is, you were actually caring for the providers, the clinicians, in spite of the fact that you had come as a patient. And that just demonstrates the depth of your commitment to others. How do you suggest we look at the well-being of our clinicians while also prioritizing the fact that the patients are coming to see us because they have needs?
Well, I think that for me as a chaplain and also as a healthcare executive, I always spent more time with my staff. And the reason for that was they are the ones who are delivering the care. And if they're not in a ready position, if they're not capable and able to provide that kind of intentional care, that focused care, that inclusive care, we wouldn't have a system that worked for the best of our veterans or our clients, public or private. So I really believe that we clinicians need to take the time to hear and see our colleagues as well, listen to their stories, intervene in their lives if need be, walk along with them. The key phrase, and Sandy and Ursula know this from my many years with them, the most important thing we can do is companion people along the journey. That means you're connected to them. And for us to have connections is mission essential, because if we don't have a connected way of knowing our patients, a connected way of knowing one another, we're at disconnect and we cannot work as a team. And together everyone achieves more is what team stands for. And we really do need to be knit together. The warp and the woof of us, we weave a tapestry together, and it comes out to be a beautiful piece as long as we allow and celebrate the diversity and the wonder that we each bring to the table. Again, it goes back to the issue of seeing every person that comes before us or comes into our life as a gift.
I love the words that you've mentioned, and I think I'd like to hear other responses, and I'm going to defer to Alex at this point in time.
Yeah, I have just kind of a quick overarching question, and what you're talking about is immensely helpful. Thank you. I'm a family physician, and I love caring for the providers, which nowadays burnout and other things with providers it's through the roof. I'm thinking on the other end a little bit now in sort of integrating spiritual care into patients' care plans and patient care. And I'd just be curious, or let me step back. I see us often doing this in the hospital when people are sick. It's done well sort of for end of life care. that's fine and all, but trying to think a little more preventive and proactive kind of long-term care. Can you talk just a little bit about where you've seen this done well, and how you would sort of envision this being part of a whole health care delivery system where spiritual care is part of this team-based care for individuals?
Well, again, it really does go back to the team. In Atlanta, we often, when I was chief chaplain there before I moved into the executive positions, I often had team meetings on the various floors with the doctors, nurses, techs, and I found that as a result of those, we could deliver more focused, intentional care. And often we would have families join us in those meetings. And as a result, we ended up with them understanding the positions and the decisions that were being made. And actually, they weren't being made without family or without the patient. They were included in the decision making, but it made many of the harder ones more palatable and easier to digest for all. Another place where I first learned the value of team meetings and whole health was at Portsmouth Naval Medical Center, where I had many people who were helped by having team meetings. We had them on every single floor, once again, particularly in terms of surgery and surgical consults. It was always a team meeting, and when hard decisions were to be made, not just end of life, family were also in attendance. It's sort of like ED today. We found in the Navy, at least, that it's very important to allow people into trauma situations unless we do not have sufficient room for family members particularly, to be with their loved ones, even if it's the worst case scenario.
Another question, I appreciate your intentional approach working with the clinical staff in the inpatient setting, Chaplain Edmonds. I'm curious as to whether you had a separate team, because I agree that the team is indeed together, everyone achieves more. It's such a wonderful acronym. When we consider that so many patients, the majority of their contacts are in the ambulatory environment, did you have a separate team that you usually worked with in that environment to address the spiritual, emotional, palliative types of needs of patients and clients? In other words, did you have a behavioral spiritual health team that worked most effectively in the ambulatory space?
We didn't formalize it in that sense, but I'd always call in people that would meet the measure of that type of team. But because of flexibility and availability, I'd have to have some key players that I would be calling in to assist in that. In terms of the outpatient arena too, you have to be very agile in that situation. It would be wise, I think, if you formalized it. But again, you have to recognize, especially in today's scenario with pandemic factors, that often people will come up positive. And so you have to be able to fill very quickly. So I think there needs to be formalization, but there also have to be players that you are ready to fill, plug and play with, and know how each other works. And that's the other piece. If you're going to have a deft hand in providing this type of care, you've got to know each other well so that you can play your roles. Again, it's specified tasks, linked tasks. How do we fit and as tight as a glove when possible?
Makes sense for sure. Harold, you had a comment, please.
Yeah, no, Chaplain, thanks for your service, both in the Navy and in the VA. And you're speaking to the kind of doctor that I've always wanted to be. And I think I've gotten my best clinical results when I succeed to some extent in being that. But you bring to mind something interesting that happened just a week or so ago. I got this email from the American Psychiatric Association that they had chosen a session that we gave at the last annual meeting is to be the course of the month for the American Psychiatric Association. And this course, what worries me about that, this course was on psychedelic assisted psychotherapy for psychological trauma. And two of the people on it were leading DOD clinicians and policymakers. One was a leading VA researcher. And I said to them when we organized this thing, look, I'm concerned that people, when you give a psychedelic like psilocybin, ayahuasca, MDMA, which these folks are all very enthusiastic about, that you're confusing that altered state, biologically induced to a certain degree, with a spiritual experience and with insight. And so they understood that my chairing it meant I was going to give a talk at the beginning saying, we've been using altered states in mental health. We stumble across them. Sometimes we develop them ourselves, mesmerism being a good example. But, what's really happening? And is the accent mark on the psychotherapy of the psychedelic? What I found, because we gave this talk some time ago, is that many people listening to the talk who have been trained in a biomedical reductionist approach tend to hear this talk as, yes, there's a pharmacological effect of these drugs that creates rapport and leads to good clinical outcomes. And what worries me about that is I don't think they see what you're talking about, that there are many ways to form rapport, that there are cases, I believe, where psychedelics could be helpful where no other way works. The person is too agitated, too distrustful. But, I'm a little concerned that we have an entire generation of clinicians who will have trouble hearing your message or mine because they reduce everything to it must be a pharmacologic effect. It's about the drug, not about people together.
I'd be similarly concerned, Doctor. I believe that especially with our focus on handhelds and computers and the like, that we've lost the ability to, or we haven't necessarily taken the time to develop the ability to stop, look, and listen. And as a result, we're not in a safe zone anymore. I believe those are intrinsically valuable to the clinical environment. And we've seen drugs overused. We have an opioid crisis to this day. We have other issues where people have fallen into using other methods to keep away from reality. I believe that companionship, conversation, good communication, taking sufficient time makes all the difference. And I hope that people just don't go to drugs as a quick fix. We need to slow everything down now. We're trying to rush people through, and rush does, say for Rush Medical Center, does not provide good outcomes.
Thank you so much, Chaplain Evans. Carlos.
Thank you so much for your presentation. I really appreciate it. And it resonates very much with my personal approach and the way I approach teams. But I wonder, you mostly describe inpatient situations. And do you think that it's possible to create a way of training staff and the full complement of the team to help us do what you're saying, which is essentially to appreciate and value the gift that each person is, but also to affirm each other in the context of our practice? So how do we go? I mean, part of the task of this committee is to bring it to scale. So how do we bring that to scale in the context of outpatient or ambulatory care?
Well, in Atlanta and every other location where I had a hand on chaplaincy, I made sure that chaplains did regular visits to each one of the outpatient clinics. They had to visit. I basically gave them regional responsibility. One person had north of northwest of Atlanta, another person had northeast, and on and on. So I had them go out, had them teach, and I also went out with them in tandem to set expectations in the beginning as to what I expected them to do, how they were to build relationship with the clinicians and nurses and staff, and then also to make sure that they were attending to the staff and working with the staff and be ready to respond if that staff had a particularly difficult situation where they could intercede. Now, it would have taken them time to get out there, but the truth is this: it makes a big difference in training, modeling, and building the rapport with those clinicians in the outpatient setting. And if you have ambulatory care or you have an outpatient setting in your big facility, again, the lead chaplain or whomever needs to work with the rest of the team to become integrated and an integral part of care plans and building that team. I was sort of a renegade and moved forward very quickly in that vein, but I owe it all to some chaplains who taught me early on that you can't wait for people to invite you. You've got to insert yourself in some cases. There are some clinicians who do invite, but that's a rare situation. So I believe that the outpatient system can be cared for, can be nurtured. Chaplain can be the pivot person, but it's also taking some time to have team meetings with all the staff and discovering each person's the gifts that they can deliver, the focus that they bring to the table, and how do we integrate specified tasks, linked tasks, boom, you've got it together. And again, it's building the rapport, building the relationship, and ensuring that you take the time required to develop those relationships that will save you tons of time later.
Thank you.
Thank you so much. Pam, I think that would be the final question for our panel here before we move on to the next speaker, please.
Okay, first of all, I want to thank you for your wonderful presentation. And I remember it brought me back to the early days of when I worked in the VA really early in my career, and we had chaplains as part of it. My question is, if just you're getting your input or take on some of the different cultures and how you address and adapt for the different cultures and different belief systems that are out there. I know you talked a lot about Atlanta, but across the country, and there's different, a lot of our veterans now, they just have different belief, even the Native Americans, I'm very familiar with those, just how you incorporate some of that or pull in the right people to be able to make them feel comfortable and to be able to have that connection, get that connection with the healthcare system.
Well, part of that is it's not an easy task, but it's one that's achievable. First of all, you've got to look for people who have an inclusive persona and who embrace all people and see all people as a gift, regardless of where they come from or what culture they belong to or what religious beliefs they have. I was fortunate at Bowdoin. I was taught very well by one of my professors about world religion, and I took to it like no tomorrow. And so I've always been a student of the world's religions and see the value in each. I chose Christianity because it's the only one that has forgiveness, but in reality, and that's a keeper for me. But for everyone else that comes to me, again, you've got to stop and listen to the story. You've got to hear where they're coming from, what part of town they're from, what is their faith. Let them tell us. We can't imprint or template how we approach each individual. I know that we have protocols and I know that we have specific questions on the charts, but take the time to see them. really see them, who they are, what they're talking about, what makes them tick, what's got them upset, what brings them in today. How may I help you? And you'll be amazed at how that unfolds before you.
Thank you so much for really launching us so well and emphasizing the approach of seeing the patient, hearing the patient, stopping and listening and learning. And as we actually heard in the chat from a patient perspective, from one of our speakers that we'll hear from shortly, the importance of having a trusted healthcare provider outweighs any drug that can be administered, and really has such important it's such an important foundational element for us to consider as we are moving forward in this work. Thank you so much, Chaplain Evans. We really appreciate just so much your contributions to the committee's work.
I call forward to the basics.
I love that. I'm taking notes as you speak because you've got so many key words. Forward to the basics. I'm typing that as we transition. Thank you so much, and have a wonderful time and a wonderful day, and continue your work.
Thank you. Blessings on you all, and a wonderful
Blessings
holiday to everyone.
You as well. Blessings during this Christmas and holiday season, Chaplain Evans.
All right.
To go on now. Okay.
Yeah, I was going to say, let's see if we can get over Zoom challenges, which I think a number of folks have had starting out with today, but we're getting warmed up. So, Dr. Kelly,
it makes us all real.
Yes. Do you think you can take us into the next section?
I surely can try.
Great. Looks like it's working.
Yeah. Okay, how's that? Full screen?
Yeah. Oh, we're seeing the slideshow or the individual slides. If you do the presentation, we should be good.
Yeah, I tried that. Let's just see. Oh my gosh. You know how many times I practiced this before this morning. Here we go.
If that doesn't work, we can work off of this. This is good enough.
No, that'll just disappoint me so much. How's that?
Perfect.
Okay. Phew. Okay. Good morning, everybody. Despite the challenges that I had with technology, I learned the limits of VA computing system. I had way too many screens open earlier, but I really actually appreciate that I got to hear Bob before presenting to you, because it's a nice segue. Also just helped ground me a little bit. So thanks for that, Bob. So this is I have a little bit of a different approach here. I was asked to speak with you about the research that I'm just wrapping up that I've conducted at the Atlanta VA. We are well represented on trauma-sensitive yoga versus gold standard psychotherapy for PTSD related to military sexual trauma in women veterans. And so I'll start somewhat with a little bit of a rapid zip through the science, since I was asked to present this research and the results are really hot off the press. And I'll highlight as I go, and then certainly really spend some time at the end talking about what all of this has to do with whole health. And so the question came to me initially, the invitation to talk about how I'm using a whole health modality in my research. And my response to that was, well, I'm not, because yoga is, because my research isn't ostensibly or actually part of whole health, and whole health doesn't own yoga. So we're going to do a deep dive. So I hope that I hope you find this interesting, and most importantly, I'm really looking forward to discussion. I have no conflicts of interest, and this study and the study that preceded it were both funded by VA HSR&D. So as I said, I'll do the quick science thing. I included the dates of this study so that you would rapidly see that this was inclusive of pre and during COVID, which adds some interesting twists when we're thinking about science as well as care delivery. I'll talk to you a bit, I'll focus really on the results of this study related to PTSD, but then the incidental finding of co-occurring depression. And then, as I said, we'll talk about what this means. And this invitation came at a very serendipitous time as I've been wrapping up the study, presenting the results, thinking about what they mean, not wanting to disseminate them in the Atlanta community because we don't have this to offer right now at our VA because it was only offered as part of my study. So sort of facing some sort of ethical questions really in terms of how to move forward, both in terms of providing the best possible clinical care as rapidly as possible and developing the science. As with everything that we do, this work has involved a tremendous team. The project is ironically named Project Stress Less. We have what I love about this study and the team is that it has been so interdisciplinary with so many people involved. Not the least of which is the women veterans who participated in the study, expressed interest and support, and really are the inspiration for this work in the first place. I suspect many of you know, but just in case, I want to make sure we're on a level playing field here. So not surprisingly, among military members and veterans, PTSD rates are higher than the general population. The most commonly cited statistic there is 20% of veterans have PTSD, both women and men. Among women veterans, PTSD is not always, but is most often related to military sexual trauma, which has an acronym, sadly. MST is defined as sexual assault or repeated threatening sexual harassment during military service, regardless of the perpetrator. So that means it might be someone in someone's unit, it might be an intimate partner, it might be off base, regardless, that is inclusive. So why this study? So the VA is really a leader in providing evidence-based PTSD treatment, and our first-line treatments are prolonged exposure and cognitive processing therapy. Those are trauma-focused cognitive therapies. They're the best we've got, but the dropout rates are about 30 to 40%. And even for those who complete treatment, the majority, roughly 50 to 65%, still meet the criteria for PTSD post-treatment, even while they've shown clinically significant improvement, they're still experiencing symptoms. So that's problematic. It's problematic to me that the first-line treatment isn't acceptable to some populations of our veterans, particularly women with complex trauma, and that while it can be tremendously helpful for some, it is simply not helpful for others. At the same time as I was learning about this as not a new clinician, but a new clinician in the VA, the use of complementary and integrative health modalities and interventions has really just taken off in our country and in the VA. And in particular, with the expansion of whole health, most VAs, in fact, offer some form of yoga, for example, for something. When I started this line of research about 10 years ago, that was not the case. And the conversations were as basic as, well, we're not sure you can offer yoga. It's kind of weird. And we're not sure people will accept it, particularly here in the South. And what if you get people on the floor and they can't get up? You know, sort of, I think we've come a long way since that point. So this study really was designed to address this gap in effective treatment, and particularly in the context of women veterans who have experienced MST, sexual trauma, to try to develop or evaluate a different pathway to healing and recovery that is not cognitive and for some traumatic in and of itself. So why yoga? So, well, yoga is really groovy, right? I mean, who would not feel better? The last time I did yoga, and I will not disclose when that was, I felt better. There's never been a time that I haven't. Well, it turns out that for some, that's not the case. And I'll talk about that more. And if I forget, someone please ask me. That all yoga is not the same. But there's a real reason that I selected yoga for this study. So the theoretical framework of my study is really based on what happens in trauma to the brain and the body. And so theoretically, and we don't have evidence of this yet, from a psychoneuroimmunologic perspective, what happens with PTSD, yoga may have the opposite effect. And so the HPA axis dysregulation, the inflammatory response, all of those things that are just associated with PTSD, in healthy controls anyway, we see that yoga causes the reverse effects. I also really selected yoga over another CIH modality like meditation because of its embodied nature. With sexual trauma, it's pretty common to be disembodied, right? Just sort of check out. So I wanted something that was embodied. So why TraumaSensitive Yoga? And lots of acronyms here, I apologize, but that's where we are. So TCTSY was designed for civilian women with chronic PTSD unresponsive to treatment related to complex trauma, specifically childhood sexual abuse. So I reached out to the developers of this modality and asked if they would be willing to work with me to try this out in the VA, and they were thrilled. And that was 11 years ago. Many people have not developed familiarity with this, so I've included a bunch of information here and some resources that you can take a look at. But what's really important here, I try not to belabor it, but what's very important is that this is all about creating opportunities for, in this case, women to experience their internal selves, their just literally sensations, feeling their feet on the floor, etc. It is very non-coercive. So for any of you who have done yoga classes at the local Y or even a yoga studio, the classes are often designed to provide direct instruction. Now do this, now do this. In TCTSY, the language is painstakingly invitational, and so that it is giving people the opportunity to practice making choices with what they do with their body. The idea is it creates safety within the body. In terms of the theory behind TCTSY, it's similar. Trauma happens to the body before the brain. It's a split second, but it happens to the body first. And so this is really a body to brain intervention as opposed to a brain to body, which is more of a cognitive approach. This is a huge study. I have so much data. I had multiple aims, but today I'll be talking with you again, as I said, about evaluating TCTSY versus a gold standard psychotherapy in reducing symptoms of PTSD, chronic pain, and insomnia. I also have a whole mechanisms of action data set. For the scientists in the room, here's the design. This was initially a 4-year study. I added a second site in year 4 in Portland, Oregon, and then COVID hit. And so we moved everything virtual from the interventions that were group delivery in person. We moved that, both the therapy and the yoga sessions, to virtual delivery, as well as all of our data collection. In Atlanta, which is the first and main site, we had 9 cohorts. The total enrollment for the whole study was a little over 200. My intent to treat sample, so those who hung in through baseline data collection, whether or not they attended any intervention sessions. In Atlanta, it was 103, and in Portland, it's 28. So it's one of the largest studies of yoga for PTSD. Only one is larger, and certainly the largest study of TCTSY. Lots and lots of measures for those of you who want to do a deep dive. So the interventions, again, when I designed this study, I opted not to have as a control condition a benign condition like a weightless control or attention control, and rather tried to escalate the science and just had the current gold standard, one of the current gold standard treatments, as the control condition. So while we didn't design this as a non-inferiority trial, that's essentially what it became. VA clinicians provided the cognitive processing therapy, and I had yoga facilitators who were trained in TCTSY. When I talk about yoga, throughout this whole presentation and in the work that I do, yoga has a lot of definitions and styles. I'm talking about Hatha yoga style, which includes movement and physical forms, some component of controlled breathing, some component of mindfulness, in this case, interoception. And then there's sort of an embedded ethical piece, although that's not overt in this intervention. So my sample, again, I described the sample size. There are some important differences between the Atlanta sample and the Portland sample. And I want to call those out. And the reason for that is thinking about whole health implementation. You know, the VA is the largest integrated healthcare system in the country. And by now, all of you, even if you're not familiar with VA, since you've started on this task force, you have probably heard what our secretary doesn't like to hear said out loud is, if you've seen one VA, you've seen one VA. And so when we think about implementing TCTSY, any CIH modality, or even whole health, recognizing that each VA population will be different in some ways is really important. The main differences between the Portland, Oregon participants and the Atlanta participants had to do with race. In Atlanta, 91% of our participants were Black or African American. In Portland, 86% were white. Typical of VA populations, this is a highly educated group. Despite their fairly severe symptoms, many were working, either full-time or less than full-time, but working. To highlight those differences again in a slightly different way with a little PowerPoint error there. Again, one of the things that's really exciting about this study, at least for the Atlanta cohort, is with 91% African American population, that's really new knowledge for the acceptability and the effectiveness of yoga for the African American population here. That's something that has been questioned, and most yoga studies are conducted with white women. So that's a big strength. And then income, we certainly had a lower household income, monthly household income in Atlanta than in Portland. At baseline, as I just mentioned, the women in this study were highly symptomatic. So the lower, darker red bar is sort of the clinical cutoff for screening measures. the CAPS and the PCL. The CAPS is really a diagnostic. The PCL-5, you're probably all familiar with, is a measure of PTSD symptom severity, and the BDI is the Beck Depression Inventory. So depression was not an inclusion criterion in this study, but what you'll see is that depression was a major factor at play here. So half of the women in the study had severe depression based on the BDI. Only 5%, and these are Atlanta data only, let me clarify, only 5% had minimal depression. So 95% of the sample had co-occurring depression of at least a mild degree. Not surprisingly, given that nearly 1/3 had experienced suicidal ideation in the past month, and nearly 1 in 4 had attempted suicide at least once in their lifetime. I specifically made the inclusion criteria for this study as broad as possible and the exclusion as few as possible, as evidenced by this. So the only reason that someone would have been excluded for suicidality, for example, was if they were in imminent danger to themselves, or if in their mind and their clinician's opinion, this just wasn't in their best interest, that they really would benefit from individualized care as soon as possible rather than enrolling in a study. Otherwise, we pretty much took all comers. As with PTSD treatment, in general, attrition in this study was high. So from screening people to consenting to then a baseline visit, which was to sort of get baseline measures of their symptoms and randomize them either to CPT or yoga, we lost nearly 1/3 of the women. That's for a lot of reasons. Some of it, life happens. Some of it, providing a group intervention as part of a study requires that you get a large enough cohort to start. And when that was slower, people were waiting too long and needed to just move on to something else, plus a variety of other reasons. After randomization, meaning, okay, you've consented, we've assessed you, now you're either assigned to yoga or CPT. We lost an additional 10% in those randomized to yoga, but an additional 20% randomized to cognitive processing therapy, which was unfortunate, but at the same time reinforced the rationale for the study in the first place. Okay, let me run through some results for you sort of quickly, and I can certainly go back if anyone has more questions. So the PCL, again, is a self-report measure. So that's something where the women describe the severity, the extent to which their symptoms are bothering them. TSY is on the left in that sort of salmon color. And what you see here is this beautiful, I think, exquisite downward trend over time. So from baseline to mid-intervention, to 2 weeks post-intervention, to 3 months post-intervention, we see this really nice drop. Time is significant, obviously, but there was no group effect, meaning there was no statistical difference in the improvement between the two groups, which is why I am saying that TCTSY performed equivalently to CPT. Another way to look at this is sort of individuals' change scores over time. And what you see here gives a different view of the data, which is that in yoga, by midpoint, so for yoga, midpoint was 5 weeks. So at no more than 5 weeks, 5 sessions of yoga, symptoms had dropped. And very few people attended the first 5 sessions. So there's something about that just provided some sort of immediate relief. I have theories about that. I will take time to go through those now. What we see in the CPT group is by midpoint, they were pretty much at the same place. The good news there is that they weren't worse. which we often anecdotally see in clinical practice, and the pitch for CPT is it works, but you'll probably get worse before you get better. So you've got to hang in there. So they really hadn't moved in their symptom severity. But then what you see, while the yoga group continues to decline in symptom severity really nicely and consistently, from the beginning of the study, the CPT group by 2 weeks post-intervention really had improved, and that improvement continued. So there are different processes here in symptom change. In terms of effect sizes, just sort of another way that we look at, okay, those are some pretty lines, but what does that really mean for people? The effect sizes here were large, meaning people didn't just get a little better. We could really see clinically and statistically significant effect sizes. And the effect sizes were larger in the TCTSY group. The CAPS-5 is a clinician-administered assessment of PTSD symptoms, considered the gold standard. And what you see here is clinicians, by asking more questions in this assessment, really identified that people's symptoms in both groups, they seem to improve in parallel, right? And as with the PCL, after the interventions ended, the TCTSY group sort of stayed the same or maybe started to climb back up a little bit, but the CPT group continued to improve. Okay, this slide illustrates a problem. Here's a problem. So by 3 months post-intervention, approximately 40% of women in the TCTSY group still met the diagnostic criteria for PTSD, and a little over 50% in the CPT group. So all those slides, all those beautiful results I just showed you, affected about half of the women in our study, right? Though people's symptoms improved, they were still experiencing symptoms severe enough to meet the diagnostic criteria for PTSD. I include these results on depression, partly really in thinking about whole health and what interventions can we use for what. Doing the analysis on the statistical analysis to really try to separate out depression and PTSD would be difficult because of the time series, and there are symptoms that overlap. But I love this slide. I love these results because what it shows us is that depression improved as well. And whether some symptoms improved first and led to the others, I'm not sure yet. But this does sort of open a line of inquiry into what else might TCTSY be effective for, even though it was specifically developed for chronic PTSD. Similarly, with depression, you see that change scores, there was an earlier improvement in symptoms in TCTSY versus in CPT, where they sort of were stuck and then improved once it was over. Okay, here's another big thing. This is huge. This is my really favorite slide. So treatment completion. Treatment only works if you do it, right? So in TCTSY, treatment completion was defined as attendance at 7 or more of 10 sessions, and for CPT, 8 or more of 12. And that's consistent for CPT with the one interpretation of the literature. There are people who say CPT completion is actually 12 of 12. Yeah, that's just not realistic. So in TCTSY, 60% of our participants completed treatment. In CPT, 38%. So when we're talking about pick your language, meeting people where they are, finding an entree into treatment, finding something that feels safe. I think that TCTSY offers some real promise, not just in its effectiveness, but in the fact that people will stick with it. In terms of the study specifically, the limitations here are that attrition was high, similar to what we see in clinical practice. Neither intervention was effective for everyone. There is no part of me that is suggesting that TCTSY should be a replacement for any of our evidence-based treatments. And then importantly, the last Atlanta cohort and the Portland cohort occurred in the first few months of the COVID-10 pandemic, and the COVID-19 pandemic. And in the context really of the political election, the racial justice movement, and unprecedented climate change events. And remember, this study was done in Atlanta, Georgia, and Portland, Oregon. So what I'm working on now, I won't go into much detail in the interest of time, is really a follow-up data collection, both PTSD and depression symptoms and other measures, including racism, experiences of discrimination, COVID impact, writ large, as well as some qualitative interviews with participants from the whole study. We invited everybody, anybody who had enrolled, who had not asked not to be contacted again, to really have a conversation with us about how all of these events of 2020 and 2021 are affecting them now, their healthcare, their symptoms. And so we are learning a tremendous amount from that. Okay, so TCTSY resulted in equivalent improvement in PTSD symptoms by 3 months post-intervention. Clinically and statistically significant changes with large effect sizes. This 22% higher treatment completion rate in TCTSY is very important in terms of implications. And the symptom trajectory may explain that treatment completion. If you start a treatment for PTSD and you start to feel better quickly, you are likely to continue. Whereas if you hang in there through 6 weeks of CPT and you're not any better, that may be a disincentive to continuing in treatment. And again, co-occurring depression symptoms improve significantly. There's actually remarkably little research that's been done with women veterans specific to depression. Stunning, but so little. When we think about women veterans, I mean, VA clinicians and scientists and policymakers, we think about MST and we think about PTSD and often ignore some of the other psychological symptoms as well as physical conditions, but that's another talk for another day. In terms of clinical and research implications, I really think that having an additional treatment option provides veterans more choice in treatment, right? So we can do shared decision-making, but if all we have to say is you can do trauma-focused therapy or nothing for your PTSD, that really limits women's options for treatment. It may be that TCTSY is a way to increase engagement in treatment. And so, perhaps offering TCTSY as a starter and then, add CPT or complete yoga. If that doesn't resolve symptoms sufficiently, then move on to another treatment. In terms of the science, there's lots to explore in terms of, this was a, one versus the other, but I think yoga as a precursor or an adjunct to CPT will probably be more effective. And I'm also lining up some research on TCTSY for men who have experienced MST. And then really the next steps in terms of research is implementation science. How do we figure out how to scale this up in the VA? And so that's where really this whole, this invitation to present to you is very serendipitous as I was thinking about next steps and implementation science. This entire week, there's an implementation science conference I'm attending with actually lots of people from VA. And it may be that whole health could create the infrastructure for implementing, in this case, specific to the research I'm talking about in the clinical care, whole health and the Office of Patient-Centered Care and Cultural Transformation are the VA home for CIH modalities. And so it may be that that can be the home, and then whole health providers provide a variety of interventions for specialty care, essentially. And so while there is robust research underway to evaluate whole health implementation, I heard a great talk yesterday about that. It really was about implementation though, and training and education and stakeholder buy-in, and not so much about, it was never the plan that they would research the literal outcomes. I think that's for us health services researchers to do. I have a few observations about whole health, and I went through the disclaimer slide quickly up front. And so here's another disclaimer.
Dr. Kelly, I'd like to make sure we have some time for questions because
Yes.
we're coming down to 13 minutes. So
yes.
if
Let
you
me
could
wrap
just,
it up. I'm
yes.
so close. And actually, this is thank you for interrupting. I do want to say these are my observations. This is the important point here, particularly when you think about the tasks facing this committee. Use of whole health modalities, specifically CIH, varies widely across the VA. And so one consideration that I implore you to take is how is it being used? So for example, yoga is in the org chart for whole health. Is it yoga for wellness or chronic pain or PTSD or just because? Also, as with some of the other whole health interventions, all yoga is not the same. So TCTSY is a specific type of yoga for a specific population with a specific clinical condition. The yoga is often provided by clinicians, and in the VA, yoga provision is tracked, but only by visit code and not for purpose or clinical condition. Local level administrative barriers such as personnel hiring, space, technology for virtual delivery are very important to consider. There's just variation across the country. And so when you look at implementing whole health, it's really necessary to recognize that while we are a national system, we have a lot of variation throughout our system in procedures and processes and how they work. Even something as simple as a position description, there's no such thing as a yoga teacher in the VA. So yoga teachers are hired as recreational therapy assistants if they're not clinicians. Some of these modalities, when we're thinking about whole health, may run counter to clinicians who are very traditionally trained. So for example, clinicians who are really invested in trauma-focused therapy, psychotherapy, are not necessarily fans of this approach. I do want to end on a more positive note, which is a beautiful exemplar that I just learned of a few weeks ago. So the VA Caribbean healthcare system is actually using whole health funds and a VA innovation grant to train 250 members of their staff in foundations of TCTSY and 10 clinicians to be TCTSY facilitators. And that's under a trauma-informed care initiative. So I think that's an incredibly creative way, an innovative way of using the whole health structure, funding mechanism, and mission to provide really specific care to specific populations. I went into a lot of detail. If any of you want to know even more about this study, this first link is a cyber seminar that I did. And then you may or may not be familiar with the evidence synthesis program. That's many of the reports are publicly available. So for those of you who want to know more about any of these topics, you can search at that site, and I'm done.
Great. Thank you so much for your presentation. And I think it's very helpful for the committee to hear about the work that you've been doing. So this is wonderful, and your thoughts. So I want to make sure that we have some time for questions. I know there's a question already posted in the public Q&A. I'm going to start with one of the first questions, because as I'm thinking about it, and it's got a couple parts to it. So I want to say why it has parts. As I'm thinking about whole health, I'm often thinking about different approaches for different people are important because everyone is different. So one of the things I'm wondering about your study, you presented a lot of means and changes. Did you look, a three-part, did you look at categorical, like did people get over PTSD or their depression go away? And do you have any inclinations as to whether those differences were different between the two different treatment groups in terms of the populations that responded? And then related to that, do you have qualitative data or stories of success from people? And can you just share any thoughts or insights about how this might work for some people versus other therapies?
Absolutely. What great questions. Thank you. So yes, we did dichotomize PTSD, yes or no. I went through the slide so quickly. So 3 months post-intervention, 40% of people in the yoga group still met the criteria for PTSD. Over 50% in the CPT group did. I have run some analyses to look at predictors of which intervention might work best for whom, right? What characteristics of an individual might lead us to recommend one or the other treatments. And really, there were remarkably few differences, at least in the Atlanta data. I haven't done that analysis in Portland. The only difference that we did see is that people who, PTSD has several symptom clusters, and one of them is a lot of cognitive sort of distortion. And so the only really significant finding was that people who had a lot of post-traumatic cognitions had greater gains in CPT than those who went in kind of on the lower end in terms of those symptoms. Other than that, we didn't find differences. Now, those might have been obliterated by people dropping out selectively, right? So there were some people who agreed to be randomized, and as soon as they were randomized to the condition they did not want, they dropped out. So that's that part. In terms of qualitative, yes, I mean, we have beautiful, really beautiful feedback from women in both groups. But I would say, and this is clearly my bias, but in the yoga group, there was a lot of qualitative data about the opportunity to feel safe, to just feel safe, as much as they could in a VA conference room.
I'm seeing lots of hands raised.
Okay,
we're down to, so
let's go. And I will come back
you,
for the Q&A later as well. I'll be here.
I'll take it in order, though. The first one was from the general public. They asked, has there been research about dosage of yoga? And then Jeanette is after that. Okay.
The published studies really have not done a deep dive on yoga dosage. And I am meeting with my statistician next week, and that is one of the analyses I expect to have the results from. And so there is a range. I didn't include that slide. If you look, these slides are available. I've sent them in. We have published interim results from Atlanta, and we do speak to that a little bit. So there's more you can learn there.
One of my questions would be, do you have any concept about the fidelity to actually participating in the sessions? Not just counting whether they logged into the session, but actually completing the entire session. For those of us who've done yoga, we realize not everybody completes the session.
Well, it depends on what you mean by complete, because one thing that's great about TCTSY is if you decide to settle into child pose and choose not to look like you are engaging, you still count as being there. People who came in late, I don't have the number in front of me, but we did discount, if people came in really late, we didn't count that session. So if you were there, you got counted, whether you looked like you were engaged or not. We focused more on fidelity of delivering the intervention. And so we had 2 yoga facilitators in every class, partly to ensure fidelity.
Thank you.
Then I have for questions, Andrew and then Pat.
I'll keep it quick, Alex. I think the dosing question was one of mine, and the other one, thank you so much. Great presentation. I'm always curious in my much more limited experience with those suffering from PTSD. I imagine many interventions, not just the gold standard CPT happening. What else? Not so much a question about what else you might have controlled for, but what else in your experience complements yoga for a group that's really looking at evidence to support whole health, not just single interventions that lead there?
Did you say you thought that was an easy question?
Sorry, I was just curious. Yeah, for it's a group you're isolating an intervention. I'm very interested in that and the dose effect, but also, what else in your experience is complementary for PTSD, particularly beyond CPT?
Yeah, I think like particularly in the field of mental health, I think there are so many paths to healing. There are people who use running or a really physical activity as a path to healing. Other people think of yoga as like white girls in tights. And so they're maybe more comfortable in a meditation session. I'm of the whatever works. And one thing won't work for everybody. And so the more we can expand our repertoire and the more we can offer options, then people can find their way.
Thank you.
And Pat, and then Gretchen.
Dr. Kelly, first of all, I really want to commend you on that study. I know personally how difficult and how much work you put into it to have put this together and pulled it off and put that so much more difficult than in a traditional university. I also wanted to comment that I think the results are much more dramatic than may appear on the surface. To basically see that you have parity between the yoga alone and the traditional psychotherapy is very interesting, because the data from which Dave Emerson published, he was working with Bessel van der Kolk, and that study, Dave was working together with Bessel, and that did include psychotherapy, from which he drew the yoga postures and that whole thing. So I think absolutely your next study should be the combination of the two versus psychotherapy. And I'm actually on the board of a couple of nonprofits. One of them is already implementing this, and I'd love to be in touch with you. And they also are ways to get VA providers trained virtually. It's another nonprofit that I'm on, and I do some of that teaching, and it's a method to standardize things, and the issue of the recreational, I had sat down with Tracy Gaudet, and that's an administrative thing, so the way to do that is to train clinicians. And but anyway, but thank you very much.
Thank you, and please do reach out.
Gretchen and then Bob.
I just had a really quick question. Did you ask the yoga clients as they came? Were they coming for yoga, or were they coming for the fellowship, to be part of something, to come and connect with other people who had shared experiences? And how important was the yoga really? Was it more important or less important than just being together, perhaps in a safe place?
Thank you for that question, Gretchen. So we did not ask that question, but we specifically discouraged fellowship. We really framed this as, this is your time. This is the 1.5 hour of every week that is your time to be inside yourself and to not focus on anything or anyone else. And so even in the waiting room, we would encourage them not to chit chat in the waiting room. We didn't police that, of course, and fellowship is fabulous, but this really was, the goal was interoception and having that internal time and space. We did not focus on that. I think to the extent that that was at play, it was at play in both of the intervention groups. So if people are going to talk in the waiting room, they're going to talk in the waiting room. And also recognizing that they're in a room with people who have a shared experience is profound, right?
Bob? Oh, you're on mute, Bob.
I just have an observation, and that is that number one, community can be infused. And number two, you've taught them a ritualized behavior, which then they can take with them. So you have imbued them with a gift that they can continue with, whereas CPT will always need the clinician, etc. So just a thought in that regard as well. Tremendous benefit in recreational therapy, and that yoga is a particularly good one. Thank you.
Thank you, Bob. I appreciate that. And your comment of giving a gift just almost reduced me to tears. So it's a good thing our time's almost up. What I would say, in fairness, CPT clinicians would say, and I agree, I think, that it's not, you don't always need the therapist. The goal of CPT is to teach people skills to manage symptoms as they occur in the future. Our trauma is embodied, and there will always be triggers. That's true for complex trauma, at least, right? And so CPT would say, no, we teach, we're capacity building here. And that may explain the drop off, the continued improvement. There's a few ways to look at that. In terms of yoga, yes, an additional premise is this is something that once someone learns it, they can do it anywhere at any time, pretty much. We also did make videos with the teachers that they had, so that they could do it at home with their same yoga teachers.
Well, that's probably a good note for us to stop here. We're with our schedule, we are at the break time period. And I'll just remind the committee members that tomorrow at 9:30, we can join on and do yoga ourselves to start off our session. So, but we have a break Eastern time here from 12 to 12:50. This is to give folks a chance to get breakfast if you're on the West Coast and lunch if you're on the East Coast. We're going to start promptly at 12:50. So please make sure you're back in time. You can just leave your camera, you can leave yourself signed on and turn off your camera and your microphone if you'd like. So you don't have to sign out, and then we'll come back at 12:50. So thank you all, and a special thanks to Dr. Kelly and Captain Evans. We really appreciate what you've had to share with us today.
Thank you. What an amazing opportunity.
Good afternoon, everyone. And it's so good to be able to reconvene after the stimulating conversations we were able to participate in this morning. I'm happy to welcome this afternoon retired Command Sergeant Major Gretchen Evans, who's a highly decorated, combat-tested woman veteran who has really been able to continue her service outside of the time in uniform to work towards really prioritizing the needs of veterans. She herself was severely injured during combat and has now reestablished a new focus of trying to pay it forward by focusing her efforts on improving the lives of her fellow veterans. As one veteran to another, I truly appreciate all of the work that she has done, serving as a mentor, a coach, a community activist, and an ambassador for the not-for-profit No Barriers USA and the U.S. Army Women's Foundation. Without further ado, so that we can have time to hear the perspective of how this project can help to meet the needs of veterans from the perspective of someone who's working actively in that area. For the next 20 minutes or so, we're going to hear from Command Sergeant Major Evans, retired, but still retired, not expired, and see whether we can have an opportunity to have about 10 minutes of questions, please, at the end of your comments, so we can really delve into the information. Thanks so much. Please, you're on.
Okay, so thank you. So since time is short, I'll get right to it. So I served 27 years in the United States Army and rose to the rank of Command Sergeant Major. And my last tour in Afghanistan, which I didn't know was going to be my last tour, but I was severely injured by a rocket that exploded to my right very close, which resulted in a very severe closed head wound, total loss of my hearing, some other structural damage to my body, and some internal injuries. But what I remember most about that particular day was when they medevaced me, I went straight to Bagram and then was put on the hospital bird to go to Landstuhl Medical Center. And they put me in a coma for a couple of days just to do an evaluation and also to pick out all those pieces of shrapnel that were in my body. And I was glad I was asleep for that part. But they finally woke me up, and there was a young doctor standing next to me with a white, dry erase board, and he was writing on it. And he got my attention, and he flipped the board over, and the words that he wrote were, "You're deaf." And I took the board from him, and I wiped those words off with my hand, and I wrote the word "forever," and he nodded his head. And so I knew a lot of things at that moment. What really resonated with me was at that very millisecond, I knew that my military career was over, that I was no longer going to be able to serve my country or be with my troops or wear the cloth of freedom, my uniform. And I didn't care that I was deaf, and I didn't care that I had a head injury, and I didn't care that there was a million pieces of shrapnel in me, and I didn't care about any of that stuff. What really broke my heart and almost cost me my life was the loss of my identity in the military, my band of brothers and sisters, not being able to serve my country. And so that was the big hill that I had to overcome. The physical part of my recovery, as arduous as it was nothing compared to the emotional and mental process of me of getting myself back together. So I'll fast forward. And so after about 18 months of pretty intensive, physical therapy to work on the physical part of my body, to regain what I had lost to some extent, that I had not even begun to address the fact that I had severe PTSD and moral injury, and the fact that my brain injury interacted with these two other diagnoses, these two other problems. Almost, at the same time, and sometimes I couldn't tell, nor could my clinicians tell which problem we were dealing with. Was it the PTSD? Was it traumatic brain injury? Was it the moral injury? Which one of these was causing the symptoms that I was having? And I can honestly say, and I don't mean this to be trite at all, especially with this audience, but I contemplated suicide. I thought to myself, it would be so much easier if I just died on that battlefield, a heroic death for a soldier, giving your all. We say all gave some and some gave all. Well, I ended up giving some, but it was almost all for me. It felt like I gave all. I felt like that I was tattered and shattered, and parts of me were still all over the battlefield. I had done 9 combat tours up to that point. So it wasn't just one trauma that we were dealing with. In fact, I sat in front of my really first psychologist, and he had taken the time to read my records, actually read my records. And when I entered his office and I sat down, he looked at me and he says, I know that protocol says that we're going to be together for 6 weeks, but I've read your records. He goes, you're going to be with me for a long time. He says, it's going to take some time for us to weed through this. And then I'll honestly say, we were together every morning for 45 minutes. He came in early and met with me before he really legally started his day, just so we would have time. Every day for almost 6 months, and never once did we talk about the war. He was establishing a relationship with me and a trust factor, because he knew that I was not going to start telling about the horrors of my life with someone I did not know. I'm not the kind of person that sits, at the bar and slings around war stories, because these are not fun. These are not great memories for me. These come at a cost to me when I share these things. It's like reliving them up to a point. So one time I got a phone call or actually an email from a battle buddy, and he says to me, Sergeant Major, I know you're having a hard time. And I just went through this incredible program called No Barriers, where they take veterans from all eras with all disabilities, regardless if it was in combat or not, and they take you on this outdoor expedition, which includes hiking or water rafting or whatever it is. And it's somewhere between 4 to 7 days, depending on what you as the veteran can accommodate. And, I really didn't want to do this because, quite honestly with you guys, I'll tell you the truth. I had tried everything up to that point. I tried medication. I tried meditation. I swam with sharks, which was not helpful at all. Okay. I sat in group therapy, which all that did was cross-contaminate me, hearing other people's war stories. It was the worst thing that for me personally was to sit there. And also, because of my rank, a lot of these young veterans were still holding their leadership accountable for the bad things that happened to them. So when they would talk about their leadership, it was hard for me not to own that, not to say, I'm the one that signed that operation order. I'm the one that ordered that convoy out. I'm the one who arbitrarily picked Sergeant A, B, and C to go out on that patrol, and they died. I made that decision. So for me to sit in group therapy and have these young soldiers tell their stories was the most traumatic thing that happened to me, other than what really happened to me. So that was not a safe place for me, because I didn't have the opportunity to tell them, listen, I was doing the best job that I could do as a leader, making decisions based on the best information that I could make. And I didn't arbitrarily just pick people. I did it with the most current and best intel that I had at the time. But I can tell you, when I looked in the mirror, it was hard not to own that. So I had survivor's guilt, and we have what you call leadership guilt. Those of us who ordered people to do things that cost them their lives. And had to find a way for me to reconcile Gretchen, the person, the wife, the mother, the friend, with Gretchen, the combat soldier. And that's not an easy thing to do. So my struggle was hard and it was real. But because my battle buddy asked me to try this organization, I did. And I felt part of the process was to fill out a medical form, because they have a physician on their staff. So when I asked you to explain your injuries, I wrote down everything that was wrong with me. Okay. And I was like turning page 2. Okay. By the time I was done, and I'm thinking, there's no way they're going to take me. A couple of days later, I get a call from the physician, and he says, Gretchen, let's talk about your injuries. And so I told him, I just, I got PTSD, severe PTSD, complex PTSD. I got moral injury. I'm totally deaf. I have anxiety. I have some depression. I have all this kind of stuff. And I was waiting for him to say, you know what, this program's really not for you. But what he said to me was, well, you're perfect. You're exactly what we're looking for. And I had not heard those words since the day I left the Army, that you're perfect. You're exactly what we're looking for. because I had been told no, I had been told I was broken, I had been told that I was too difficult. The VA, although I got great care, and I'll tell you, I've gotten great care at the VA. I'm not an easy patient. I'm complex at best. When one doctor makes a decision about my care, it affects all the other areas in my healthcare. So if they don't communicate with each other, it's problematic. And so I have to really am the perfect example of what having, we call a pack, really means. So if my primary care doctor wants to switch medication, he or she must talk to my mental health person, because what he or she may be prescribing could interact with what I'm already on. And they take the time to do that. And that's what's kept me healthy and safe and has been able to allow me to progress. So I went on this expedition with no barriers. And I'm going to try now, I'm going to do my screen save and just go through a couple of really quick slides with you, because this is a pretty phenomenal organization. Hang on just a sec. Okay, can you guys see that?
Not yet.
Not yet, Richard.
Okay, hang on here. Okay, I know what I gotta do. Share screen, there we go. Okay, can you see it now?
Still not seeing it.
I just practiced this and it worked just fine. Share
Looks like help is coming. Great. Yes, now we're seeing the screen.
Okay. Thank you so much. Sorry for the delay. Okay.
It's okay.
So here's just an overview of a picture. This is a group of veterans climbing a mountain. So the basis of No Barriers is, the mantra is, what is within you is stronger than anything in your way. And it's not just a mantra, it's really a way of life. And you have to believe this. And I say this to my troops all the time when I talk to them. Regardless of what happened to you, whether you got blown up, whether you're missing your arms or your legs, or you have a traumatic brain injury, whatever it is, you're still that same person that you were when you rose your hand and you swore to defend the country against foreign domestic. You might look different and you might feel different, but deep inside of that, okay, you still have that strength within you, and you have to remember that. So there, there's the mantra, what's within you is stronger than what's in your way, and there's power in those words. So, but what No Barrier does best, I think, and I've been through a million programs, I really have, and all of them offer something, but I've never found one that's as comprehensive as the No Barriers program. So part of the thing they realize is that when military people leave the military, regardless of what reason, even on their own accord, the first thing you have to do is redefine who you are. So I went in at 19 and I was wounded at 46. 27 years I spent in the military. I had no idea what the civilian life was like. Okay, so I had to redefine myself. I was no longer Command Sergeant Major Evans. Okay, now I was something else, but I didn't know what that was. I had to redefine who I was. And then I had to find my new passion and purpose. I was no longer able to serve my country in uniform, but that didn't mean that I couldn't do something that was useful and it was meaningful. And this was not a quick process. This was a 3 or 4 or 5 year process. Little by little, this new me developed. And it took a lot of people to do that. And I call it a rope team, and I'll get that to in a minute. And that was part of the build a community support. And I did. And I reached out to people, and I asked for help. And I got a great primary care doctor. I got a great mental health provider. I got a great friend in Dr. Leak, okay, who at the time was the mothership of all the nurses. I don't know what you call yourself, Sandy, but Sandy knew that I was complex, one of the most complex patients probably at the VA at that time. And there were times, and because of my deafness, I had to go in for surgery. I'll give you an example. I had to go in for surgery. And of course, they mask up when they're in surgery. I read lips. So all of a sudden, I'm getting operated on and not able to communicate with my surgical team. And that's a very scary feeling for me. And so Sandy got permission to go in with me and be a translator for me. Okay. And that brought me great relief. And that was thinking out of the box for a patient that needed something other than just the normal protocol. No, I don't know how to do that. Just the other protocol. See, she realized that this is going to be a problem for Gretchen when she gets in the emergency room, and also waking me up in recovery. A deaf person, I'm waking up. May not remember where I am. You can't just come over here and put your hand on my foot and expect me not to come out of bed, explosive. I was coming out of amnesia. The last time I did that was when I was blown up. So there was always all this that was taken into care. And then part of the program too is believe in our potential again. So as Robert talked about, as you're caring for your clients, as your patients, okay, you have to instill a belief in them that it does get better. I had a doctor actually tell me one time, Gretchen, this is as good as it's going to get for you. Thought to myself, surely not. Okay. And I felt like if I didn't stick my foot in this proverbial shutting door, that I was going to lose myself. I thought, no, this isn't as good as it's going to get for me. I'm going to fight for anything that I can get back. So here's the kind of what Novarious brings to this. So they had this transformative curricula, health and wellness, and nature-based healing. Okay, and you see the little rope symbol in a minute. That's the rope that ties these three things together. So they have a curriculum that they take you through. You just don't go for a walk in the mountains. As you're walking on this hike, okay, they're teaching you things. And I'm going to jump right to that because that's really important. That's how many people they serve. Okay, we'll come back to that. But I'm going to get to you. Here we go. So this is what they instill in you is their curriculum. First of all, vision. To find a purpose that inspires you to give your best back to the world. We all have to have a vision, something that inspires me to get up every morning and give my best back. And we talk about this. Reach, move beyond your comfort zone. Okay, pioneer, persevere through challenges and innovation. I had to persevere through the fact that I was one day a hearing person and the next a deaf person at 46. That was a world changer. That was a life-changing event for me. Rope team. This is my most important thing. I have people in my life that I can call on. And what this really resonates with military people is we literally tie ourselves together, okay, when we're traversing really steep terrain, like in the mountains of Afghanistan, okay, because as we're going up this steep mountain, we tie ourselves together. So if someone slips and falls, you don't fall far because the rest of us pick in. So you might only fall a couple of feet rather than hundreds of feet, and maybe even to your death. Sometimes you're the person that falls, and sometimes you're the person that picks in. But either way, you're in a position where you're giving back or you're relying on others to help you get back up when you stumble. And it's a great life metaphor, okay? There's not one of us on this call that hasn't been kicked to the curb at least once in their life. And who are those people who picked in with you and waited for you to be able to stand on your own and continue on your mission? We must set up our veterans so they understand how important their rope team is, but also that they have to give back, that you're on that rope team yourself. So it's not just you falling. Sometimes you're the picker. This is what has saved me a million times, knowing that there's people out there who will journey with me in the highs and the lows. And also another beautiful thing about a rope team is, I'm a big hiker and a big adventure racer, is that when I do something really great, like I hike a really tall mountain or I finish an ultra marathon or an adventure race, I do it by myself. I cross the finish line and it's almost anticlimactic, like, okay, so what? But if I do it with other people, there's a sense of camaraderie that we did this together. We got to the top together. I think it's very healing to do that. And it's very giving back. Then we talk about summits, okay? Find the gifts earned through the struggle. So summits can be that I can go a week without having nightmares. That's a summit for me. A summit can be that I can walk into a Walmart store at peak hours. A summit for me can be that I can drive down a windy road without worrying that there's going to be an ambush around the hairpin curve. These are summits in my life. These are moments that I didn't have before. These are worth celebrating, and they didn't come easy. And then the last one is elevate, impact the world as a leader who serves, give something back. We cannot be self-licking ice cream cones. We have to find a place where we can give back in the best way that we can. Because as we all know, okay, that's where real healing comes from, when the focus comes off of you and goes on to others. That's when you walk out at the end of the day and you say, wow, what a great day that was. I was able to help somebody else. And in that process, I actually helped myself because I gained confidence in my ability to do things. And for a little while, maybe the focus wasn't just on me. Now,
Gretchen, I'm going to ask you to forgive me. Your presentation is just unbelievably valuable and moving, but we would like to ask some questions. And we have a shortage of time. And I hate to do this, but I'm gonna. And because I really, what you're presenting, first of all, is that you are the most articulate person I've ever heard talk about what it means to form your identity as a servant, but a servant serving your country in uniform in austere environments. And the change in who you think you are when you take off the uniform perspective. And I just want to say thank you. What is it that you would suggest our clinicians and everyone who works with veterans needs to know, or how do we help them understand this? Because now less than 1% of the population is a veteran or knows somebody. So how do you suggest we get this message across?
I think that it's important to, if you're going to work with veterans, that you understand at least the basics. I always wanted to teach a veteran 101 class to every clinician in the VA. Please understand the differences in the branches. Please understand rank structure. Please understand even basic job description so that you can have a somewhat knowledgeable conversation with the person you're talking to. It's being engaged. What branch? It's easy to ask, just what branch of service were you in? Oh, you were Army. Great. What did you do in the Army? And maybe they'll answer you, maybe they won't, but at least you're engaging them in a conversation. And the other thing is, do not let them walk out of your office without hope. It doesn't mean that you're going to cure them. And it doesn't mean that for me, my brain injury is still engaged. I'm still deaf. I still have PTSD, but I'm so much better than I was in the beginning because people believed in me. They believed they could help me. And when they said it, they meant it. And there was a commitment, there was some skin in the game, both on my side and on the clinician side, that we're going to work on this and we're going to try to get better. And they became better clinicians. I had lots of my clinicians say, you make me use every tool in my toolbox, Gretchen. You have made me a better psychologist by allowing me to walk through this process with you.
Thank you. Thank you. I'm going to ask another question while my colleagues are raising their hands somewhere. And that is, you've made a couple comments about the difference you perceive, not just in your senior leadership position, but your age. You started at 19, and then when you were injured so severely, everyone was much younger, and now you were being thrown into the mix for your therapeutic interventions with these young people. And as a mother of 2 combat veterans, I remember vividly saying something, well, I had to get a hot water bottle. And my son said, what's a hot water bottle? And I'm sitting there going, we speak a different language here. What do you suggest we think about when we talk about the generational differences, not just amongst those who've been injured, but those who are clinicians? You may have a 25-year-old physician who's caring for a veteran. Right. What would you suggest to help manage these generational differences?
Again, just being current. I mean, even if you just bring in someone like me just for a symposium and say, okay, we don't call them C rations anymore. They're called MREs. And we don't wear BDUs anymore. We wear Army combat uniforms. And now we're wearing the pinks and greens. We're not wearing the blues anymore. Just this updated and all, women can serve in any MOS that they can qualify for in all branches of service now. So don't be surprised when you start treating a woman who's now a ranger or a woman who's gone through special forces. And, you know, and things like this. It's just a matter of being current. And I think that the easiest way for you to do that, really, not everybody's going to sit down and get current on the military. You guys are busy people. So bring someone in, okay, who knows this and who's willing to do this and do a lunch and learn or do your continuing education hours as part of being current with the current military and the injuries that are happening to us. Now we're dealing with these burn pit issues, which is a whole nother ball game, okay? And all these kinds of things and the things that the veterans are really struggling with. So that you are asking questions that they're not going to roll their eyes at and say, really? Okay, that's like we haven't worn that uniform in 20 years, or we haven't used that weapon in 20 years, or whatever it is. I think that just you need to incorporate that into your educational process.
Thank you so much. Pat, please, what is your comment or question?
Thank you so much. I'm just speechless at how wonderful this is. You brought up something that I have never, ever heard brought up, and it just strikes me to the core. And that is, I also was in a leadership position, and my son is a Afghanistan combat veteran. And this thing about this anger at the leadership. And I just wonder if you could say a few words more about that. When that comes up, I just sit there and I'm speechless. I just, no one has, thank you. No one has ever brought that up, and I just don't know what to do with that.
So it's not because I think you don't know about it because we don't talk about it, because, you know, we are leaders and we are very stoic. You know, after about the 30th memorial ceremony that I put together in Afghanistan, you can't cry. You're the leader. They're looking at you. And if the sergeant major starts crying, all hell's, it's all gone to hell. So you're very stoic and you don't talk about what it feels like. It really hit me when I'd send out a convoy and somebody has to sign that. Okay. It's a senior person. So lots of times it'd be my signature. And like I said, someone would die. And then you get the convoy order back, and I'd look down and there was my signature. And I think that senior officers feel the same thing. Somebody signs this paperwork of this operation order, this task force to go and do something. And it's hard not to own that because you made those decisions. You came up with that plan. And when it goes haywire, then it's hard not to feel guilt about that. And it took me years to be able to say, I did the best I could with the best information that I had. I made the best decisions not to put my soldiers in harm's way. Unfortunately, in war, people die. It took me 10 years probably to be able to say that.
Thank you so much. Margaret, our last comment.
I have just a question. I think that I was really struck by the entire presentation. And I think that you're bringing up something so very, very important, that in our panel's work, we are going to be looking at the evidence for, this idea of whole person health and what have you, whole health. And we have sort of a typical way that we do that. And that is we randomize people to treatments such as group therapy versus no barriers. And in fact, Dr. Ursula Kelly's study, which was stellar, was designed the way it's supposed to be, which you randomize people to one of the two treatments. And what we saw was a tremendous dropout. And one of the things we rarely study is, what's the effect of that dropout on people? Why do they drop out? Do we follow them up to find out that they feel like they didn't fit? And so I just wanted to ask you how you would have felt if you had been told, well, you do fit into our overall program, but we're going to randomize you to either a group therapy, which you've already told us was it was traumatic, or no barriers. And do you have any wisdom for us as we look at the research and we propose how research should be done? Should we move from this way of doing research that came from studies of drugs to something that there's another term, it's called implementation science, which allows us to ask, what would your preference be? So I just like your comments on that. As we look at research, should we be just focused on this narrow design or being more open?
So my opinion about that is much decision making that you can give to the person who's trying to get well, in most cases, is the best. You know, nobody knows yourself better than you. You need the clinician there because sometimes you can't see the forest for the trees because you've been traumatized. Okay, and they have the skill set to help walk you through that, and they have some information that you don't know. Okay, but if someone were to have asked me in the very beginning, okay, would you prefer to have sertraline and clozapam cocktail, or would you like a service dog? I would have picked the service dog first, okay? Because there's not a medication that you can give me that does for me what my service dog does for me. Okay, but I didn't know that was an option, nor was it offered to me. There was a protocol. Okay, you get it, the protocol that is you put them on enough medication to get them stabilized. Okay, and I think there's some truth to that. Okay, if you're all over the place emotionally and mentally, okay, you do need to be stabilized, and maybe a little bit of sertraline is not a bad idea. Okay, kitten doses to start with. Okay, so that you can receive the therapy in a way that it can be helpful. But as soon as you can, we should start diving into that person's. That's why you got to know a little bit more. Other than the fact PTSD is an acronym for all kinds of things, okay? And it affects people all kinds of different ways. So we can't just put it in a box and say, okay, this is how we treat PTSD, because it's different for a female than it is for a male. It's different for someone who's 21 than it is for someone who's 46. And so I just think that there should be lots of options in the very beginning, because you can always revert to the last thing we probably all want to do, and that's to medicate somebody. Because once you start down that road, it's a slippery slope sometimes. Okay, not that medication's bad, but I'm just saying there's other things out there.
Thank you so much. This has been incredibly meaningful. Command Sergeant Major Evans, you've given us a gift today. And I'm going to flip over to my colleague, Alex, for our next presenter. Be well.
I'll echo the thanks. So very, very important voice and powerful story that's going to help shape what we need to do this afternoon and tomorrow. Our next session, I'm excited to introduce April Kyle, who's of Athabascan descent, and she's the president and CEO for South Central Foundation's two-time Malcolm Baldrige Award-winning NUCA system of care. And the NUCA system is a customer-owned system that provides healthcare and related services to approximately 65,000 Alaska Native and American Indian people. And NUCA's earned a national and international recognition for their quality of care. Most recently, April Kyle served as the Vice President of Behavioral Services, which includes crisis, outpatient, integrated, co-located, day and residential program and services. She shared with us that she's a mother and she's a customer owner, and she speaks regularly nationally and internationally on various topics, including whole health system transformation, behavioral health leadership, and innovation in the industry. So all things that we need to hear about. April, I'm going to turn things over to you. We'll have some time for questions with you, and then around 1:50, 1:55, we'll be turning to a general question session too.
Wonderful. Well, thank you. I just want to start by appreciating the last presentation, which I thought was super valuable. So thank you for that. We have a slide deck. I'm hoping you can see me in the slide deck at the same time. Is that possible?
Yes, we can.
Okay, great, perfect. So my name is April Cayo. I serve as our president and CEO at South Central Foundation. As I was introduced, I am Alaska Native Athabascan from a small village called Ninelchik, which is about 3.5-hour drive from where I'm sitting today. And I have grown up in our system. I've been here for 18 years, serving in a variety of roles before this one, leading our behavioral health work. And I am very excited to share our story today. I plan on talking for about 20 minutes and then pausing so that we can see what questions or comments you might have. Next slide, please. I'm going to talk a lot about our philosophy and approach to whole system care, but I like to start with the data slide because all of that philosophy only matters if we are proving it out in the data. And so as we as Alaska Native people have redesigned our healthcare system, we've experienced things like 44% less ER visits, a decrease in inpatient use, and around HEDIS measures, a significant increase in our outcomes, consistently performing at the 75th percentile and often performing at the 90th percentile. Strong balance between customer owner satisfaction, how Alaska Native people feel about their healthcare system, and that balanced with employees and employee engagement and how employees feel about their connectedness to our work here. Next slide, please. So to understand our story, just a little bit of history is helpful. We came about because of the US government's obligation to provide healthcare to Alaska Native people, a treaty obligation that began with the Indian Health Service. And when I was a kid, I received my care from our IHS hospital that was here in Anchorage. And I'll share with you that for me, we went to that hospital when my dad didn't have insurance. It was seen as the second-class place to go, woefully underfunded, never met the needs of the full community. And it was so sort of overrun with demand that everybody entered through the emergency department. And along came something called the Indian Self-Determination Act, which allowed Alaska Native people to assume control of our own healthcare systems and to really be in the driver's seat of wellness for our communities. And that's a little bit of the story I'm going to share. What does it look like when you give control of healthcare to people in communities and they can design systems and services that truly meet their families' needs? Next slide. We are driven by a vision and a mission. Some of you may have worked places where you had a vision or a mission that hung on a wall somewhere, but other than that, you didn't know about it. This is really kind of our heart and soul as an organization. Our vision is a community that enjoys physical, mental, emotional, and spiritual wellness. So we believe that each of us, and I'm looking at you right now, you and me, have within us in this moment a balance of physical, mental, emotional, and spiritual wellness. And that those things are connected. They can't be separated. And how we're doing sort of physically impacts how we're doing mentally, how we're doing spiritually impacts how we're doing emotionally. And because those are so connected, you can't just say, oh, good, don't worry, we have behavioral health. It's in that building over there for that one uncle in your family who needs it, who can go there on Tuesdays at 2 o'clock. Instead, we think about our entire system being designed so that as we are interacting with community, that multidimensional wellness is in the forefront of our service delivery. Our mission, how we get to that vision, is by working together with the Native community. The key word there is working together. So it's about how we sit in relationship with community. We see the core product of our healthcare system, our output, is the quality of relationship that we can sit in. So if you think about a healthcare system that is truly owned and managed by its community, at a macro level, you have to create systems for community to be the driver. That means that as a president and CEO, my job is to listen to the voice of community and be driven by that voice and to support the deployment of the resources of the organization to meet that community's need. I'm going to give you a real example. My next meeting today is with one of our villages where we operate a clinic in their community. That village appoints a health council. That health council meets throughout the year. It's chaired by a local community member. It represents family in the community, and they are the on-the-ground governance of their healthcare that we operate at their direction. And I'll be spending hours today both sharing, but mostly listening to what their needs are in a community and then making sure that our system is deployed to meet their needs. So that's macro level what working together looks like. At a micro level, we want that same sort of partnership, relationship, and listening to happen between every care team and every family. Next slide, please. We think words matter in our system. So in healthcare, you usually hear words like patient or client or consumer. That really doesn't describe the relationship that we have as a healthcare system with Alaska Native people who come in to receive services. So for us, we use the word customer owner. We never say patient. And that reminds us that that person or family who comes through the door today is really the owner, both of the system at large and also of their healthcare journey. We are working intentionally to break the hierarchy in healthcare that exists between system and people and to rebalance that in relationship. Next slide. I have so much to say. I know I'm talking quickly. Bear with me. I really want to give you as good a picture as I can in 20 minutes. These are our goals. The first is this idea of shared responsibility. It's how we walk in partnership with each other. The second is commitment to quality. We think we can, Alaska Native people, provide the highest quality healthcare services to our community. And we can do that by employing Alaska Native people and supporting the growth of Alaska Native people to be the leaders of our organization. The last one is family wellness, and I want to spend a minute on this. So we value the family as the heart of Native community. When I work with other healthcare systems, I think you can take that word Native community and just say family is the heart of our communities. And our goal is way bigger than the prevention of illness or the treatment of disease. Our goal is physical, mental, emotional, and spiritual wellness for people, families, and communities. And we think that healthcare normally is primarily about the physical wellness of a person. But we know that our wellness is multidimensional, and our wellness, we don't live alone in this world, right? That we are on a journey with the people who we journey with, whoever we call our family. For me, my partner, my children, my parents, and how we are doing as a family impacts the wellness of each person in that family. So family wellness becomes a focus. And then also that we as families are living in a community. And the fabric of that community can either support our wellness or it can cause harm. And so we think about how do we support the wellness of community, which impacts the wellness of family and wellness of people. I'm going to give you an example. I was in a meeting with one of our tribal councils, our health councils, governance, local governance of healthcare, and they said there was a dilapidated ball field that they wanted to sort of clean up and create as a place where community could gather. And there was a building, there was a bar there, but they wanted to create a space that was healthy, and they wanted to have an espresso machine. It was going to be a community gathering place. Is that what you think a health council would discuss related to the delivery of healthcare services? Should our healthcare employees take some time off work and go help clean up the ball field? And should healthcare dollars be spent to buy an espresso machine? Absolutely. I often say that a behavioral health intervention can be open gym family basketball night at the school. And I just have to convince Medicaid that they should be paying us for delivering that type of service. Next slide. So when we talk about the importance of walking in relationship with community and with customer owners, we do that based on this idea that each of us has a story behind our eyes. And we want to create a competency as a workforce of how we walk and journey with each other by sharing and receiving story. So if I share with you a little bit about me personally from my heart, and you receive that as a gift, and you share with me a little bit from your heart, and we can't do that right now while only I'm talking. But if we were together and we could do that for real, that thing between us, that idea of story is where relationship happens. And every new cohort of employees will do the normal new hire orientation. Then they spend 3 days with me and 2 other facilitators, where we really dive into how we use the power of story every day in our work with each other, in our work with customer owners, in order to build that relationship and partnership as the way that we operate healthcare. Next slide. We have an analogy that we think is helpful when we think about how our healthcare system is different. So play with me for a minute. Imagine I'm holding a rock, and there is a target, and I'm going to throw this rock at that target. If I know the weight of the rock and I practice, I can get really good at hitting that target. Now imagine I'm holding that rock and I throw it, but instead of a rock, it's a bird. Does the bird fly to the target? The bird, unlike the rock, is thinking. It has free will. It has its own motivations. So if I want to think about where that bird is going to go, then I probably need to understand what motivates the bird. I need to understand the bird's nest, the bird babies, the bird food, and reorient my thinking or my target to what the goals of the bird are. So next slide. I like the bird and rock. This is probably an easier way for you all to understand that same idea. On the left-hand side, we have control. On the bottom, we have acuity. So start on the far right. Imagine a high acuity situation. So let's say I got hit by a bus on the way to work and I'm in the emergency department. I am not interested in the ER doctor understanding my story and knowing my motivation and what I value in life. I want that ER doctor to save my life. Be very good at precision, throwing that rock and hitting that target. But most of our lives are not in high acuity situations. Most of our lives are in lower acuity situations. Our wellness is driven by the things I do every day as I walk my journey, what I eat, what I drink, how I parent, how I manage stress, whether I take the pill, skip the pill, fill the prescription, cut it in half, get one from a neighbor, share it with a friend. All of those decisions are what actually drive my wellness. And as I walk that journey, who's really in control of that? The customer, owner, and family, and the system has very little control. And if we acknowledge that, then we realize that most of the way that we impact wellness is not throwing rocks with precision. Most of the way we impact wellness is by becoming increasingly a trusted partner in relationship. So that when I, as a mom, think, I don't know what to do with my kiddo, I think, do I want to chat with my mom, my girlfriends? Do I want to call my case manager? Do I want to call the behavioral health consultant that's on my primary care team? Because they're a trusted partner who I know the name of, who I know understands my story, and who I trust to talk to about what's happening in all of the parts of my life that I have control over. Next slide, please. Lots of people look at our system from the perspective of our primary care model. So if you've heard about us, you know that back in the 90s, we were on the front cover of the New York Times for an advanced access, same-day access primary care model. We've integrated behavioral health and primary care for something like 18 years. So I'll spend 1 minute sharing with you about how we do primary care. This is usually sort of a multi-day long session. So what you're looking at now is a diagram that shows the customer, owner, and family in the middle. And the blue around the customer, owner, and family are the primary care team. So that team sits together in a pod, a primary care provider, RN case manager, a CMA, and the CMS is a skilled administrative person who sits in the pod and does all of the scheduling. It's who I call directly. I never call the front desk. I'm always calling my own team as a mom. And they have a panel of customer owners that's maybe 1,200, 1,300 people. We'd like it to be lower. We're always working on figuring that out, who they are going to be in relationship with over time. Around them in orange are people who work in primary care and who are integrated. So the behavioral health consultant on the upper left is a master's level clinician. Their job is to be available and pulled into the care delivered by the primary care provider. Same for the certified nurse midwife, dietitian, the social worker, and pharmacist. Around them, you have co-located services working in primary care all day. We have a psychiatry team. They do consult-based care. They provide no direct care to customer owners. Their job is to support the primary care team when they need to consult around a prescription, but keep that care in the primary care relationship rather than referring out. And you can see the same thing around HIV, pain, colorectal, pediatrics, et cetera. Around that, you have specialty services where you actually leave primary care and go to another clinic, receive care, and then come back into primary care relationship. So if our focus is on longitudinal relationship over time, then as much as makes sense to do, we want those resources to be integrated into the primary care team so that we can deliver those in real time to customer owners when they need it without having to refer out to other places. But you can't do everything in primary care. So we have service level agreements where we talk with these outside specialists about how we pass care back and what the pull discharging into primary care looks like after that specialty care is received. Next slide, please. To do this work, we are asking primary care providers to live and work differently then they might practice medicine somewhere else. We're asking them to walk in partnership and in shared responsibility with customer owners and to actually share their story. So I know, April, about my primary care provider, about his kids and nieces and nephews that he loves to run and how hard it was when he had a surgery and couldn't put those running shoes on for months at a time. And he knows a whole lot about me, and he's a phone a friend who I want to talk to about the things that are happening in our family. Next slide. We work with lots of systems that are thinking about integrating care and primary care. And one of the main flaws that we see is this model, where you have a provider and all of the workflow happens through the providers. They become the rate limiting factor of what the primary care team can accomplish. If you follow this model, that the provider or physician is going to be the gatekeeper of all of the care, then no matter how many people you add to that primary care team, your output is restricted. Next slide, please. So we've worked really hard on the idea of parallel workflows so that I, as a mom, can reach out and talk to I have gigantic kids. I have a 15-year-old with a men's size 16 shoe. Trust me, I talk to that dietitian all the time. He was so big, I was like, do I move to non-fat milk yet? He's 2. And that was someone who I could work with directly without having to talk through the medical provider every time, but really maximizing the contribution of each person on the team so that they are interacting with the family and with the specialists in real time all the time. Next slide, please. So if you do this primary care thing well, and you really talk with families about multidimensional wellness, and you have integrated master's level clinicians, you start to unpeel the onion and learn all these other things that are happening in our lives. And if you're going to do that, you've got to have specialty behavioral health with population access, trusted partners who you can refer to. And we've invested heavily in building a continuum of behavioral health services. And if we ever have time for that full conversation, I'd love to discuss what it would look like in our country for us to really invest in behavioral health in a way that could meet communities' needs. And the failure to do that costs our healthcare system a lot. But we at CF are trying very hard to build out that access so that we have both specialty behavioral health and integrated behavioral health in lots of places across our system. Next slide. We also do a bunch of things that you wouldn't normally think are healthcare. So we have Family Wellness Warriors, which is working to end domestic violence, child abuse and child neglect. We have an elders program where we really think about bringing elders together, elders drumming, elders dancing, bingo, food. We have home visiting programs, mother-baby programs. We operate in the clinics, have clinics in the shelters here in town. We have a Soldier's Heart program where we partner with veterans. We have a men's wellness program. We have this idea called learning circles, which is about the power of people who are in shared place in life coming together. And that you really don't need a healthcare person to be delivering a service. That if I'm a mom of a kid with a really scary diagnosis, it might help me to be in a room with other moms who are experiencing that same thing. And we now have like 90 of these learning circles happening across our system where you don't have to sign up, you don't register, you don't have a diagnosis, it isn't in a treatment plan, you just are able to come in and be in shared space with I kind of say it's like sitting around a campfire together. And we don't always have time to sit around a campfire together in our busy lives, but if we make time for it, we know that it's healing. Next slide.
Well, can you try to wrap up in 1 minute so we have time for questions?
Yes, I can. 2 slides left. Thank you for the reminder on time. Just really quickly, so to do all of this, figuring out the ways that I listen to voice of customer and that it drives every level of our system all the time. Next slide. And that doesn't just happen once, that we're doing it through all of these different ways. Next slide. And then really celebrating and giving acknowledgement to Alaska Native people for what they've created, and that instills pride in self. And so giving that recognition back to Native community. Next slide. And we have lots of ways that people come and learn about our system. And for me, that's an opportunity to interact with other systems that are doing cool and unique things that we can learn from and think about in order to solve some of the things that we're working on in our system. Next slide. Okay, I got to thank you in like 1 minute. And I know I covered a lot and talked really fast, but I appreciate having an opportunity to share.
That was extremely helpful. Thank you so much for sharing that. And I really like the customer owner model. And for our committee, it's really helpful to see and hear about different ways that groups are approaching things. I'm going to open up the questions while others think about whether they have questions. And one of the things I've been wrestling a little bit as we've been thinking about whole health is sort of who we're caring for. And I noticed at the beginning, you started talking about community care, and then your primary care diagram flipped very much into care of an individual. And then at the end, we went back to the care of a community. What are your thoughts about sort of that integration, about whether a whole health, how whole health systems care for communities and individuals, and what that means?
So I'll give a quick two-part answer. The first is that everywhere in our system, our goal is to understand what's happening for whole person wellness and family wellness. So I'll share with you that my dad was in the ER recently, super scary, right? And I got a call from his doc. How are you doing? Right? How are you, April daughter, doing? I know you were there with him at a time when our hospital couldn't allow visitors in, right? So that doc's responsibility is not just to my father, but to our family and to our family wellness. And I'm moving through a transition right now where my parents have taken care of me for a long time. And I'm in that moment where I have some responsibility to take care of them. My dad's put me in the chart as his responsible person. And so that kind of relationship is changing between my dad and his provider and me, and we're navigating that. And that's family wellness, right? How are you doing? Do you want to talk to the behaviorist, April? That sounds really scary. Sounds like a really scary thing happened. And then also to acknowledge that there's a time and place where we're going to deliver optometry and audiology and dental care and orthodontics. Think about orthodontics in teenagers. With braces. Braces might be the big deal that's happening, but do you think that you end up talking about other teenager stuff in that visit? Do you think that a behaviorist integrated into orthodontic care would make sense? It makes sense to us in our system. So really thinking about everything that you design and how it can be about the whole person and family wellness.
And just to wrap this up, and then we'll turn to Sarah and then Pat, and this can be a very simple yes/no response. So if you're thinking about who a whole health system is responsible for, I'm assuming they're not just responsible for an individual, but also an entire community too. Would you agree with that?
Absolutely. Yep, absolutely.
Sarah?
Yes, thank you, April. That's such a wonderful presentation, and it's such incredible work that you're doing. Really appreciate it. My question relates to the primary care model that you showed with the concentric circles. And a lot of what you talked about was kind of the importance of holding things as close to the customer owners as you could. And I wondered, as you moved out those concentric circles, you mentioned the service level agreements that you have with the specialists outside. Can you say more about that and how you ensure that the kind of necessary information keeps coming back to the core to make sure that the whole health of the patient is contemplated?
Yeah, I would be happy to. I'm going to use cardiology as an example. When a primary care team is thinking about a referral to cardiology, wouldn't it be nice if you could ping in the system and that cardiologist might be able to make a phone call in real time while you're in the conversation with the customer owner? And how often do you really need a referral, or do you need a consult, right? When do you do a consult and when do you do a referral? Now, the problem is that we operate in a fee-for-service state where referrals make money. But what would be the right way to deliver that care? And if you're thinking about really leveraging our dollars to provide services to community when they need it, and that we are most comfortable receiving care in places where we have relationship, then we really want to push the boundaries for the difference between consult and referral. So when a specialist receives a referral, they often say, well, wouldn't primary care have done this? Wouldn't they have done that? I would like for this to have happened. And the leaders of those two clinical services will document, here's what we're expecting primary care to do before they refer. And here's what we're expecting specialty to do when they refer back. And the refer back is equally responsible to primary care to pull that refer back as it is for the discharge to come from the specialist. And what happens is we write those service level agreements, we document it, it's an agreement that's signed between the two. And then we find that the actual practice varies 2 or 3 years later, which prompts those leaders to come together and reevaluate their service level agreement and reconfirm sort of what they anticipate should happen as that care flow transition takes place.
Thank you.
Yep.
Then Pat and Pam, and we'll try to close up around 1:55 for the general discussion. So I don't want to rush this one.
Yep. Thank you very much. And this dovetails on the last question, and it's just too much for this present time right here. I love what you're doing, and I think it's much more whole health and how I think a lot of us think about it. And I'm trying to figure out, as we discuss this more with the committee, how would we be able to get more information about how you handle payments and the funding of this model? Because you did mention fee for service, and that's all I'm going to ask. Maybe not spend a whole time, but direct to Alex is if there's a source that we could read, or for me, just out of curiosity, to be able to have that as part of our deliberations.
So I'll share a couple things. One, and I'll be really brief, that you could tell it was hard for me to tell this story in 20 minutes. And we have folks who come up and spend a week with us, learning about the system and experiencing really how we do this work. So would love to figure out if there's topics of interest, how we share those with you, and maybe bring other experts from our system to you. We operate on a cost-based encounter rate through the Indian Health Service, so it's a little bit different, but we've consulted with lots of systems. And I'll share with you our big conference we have up here in Alaska, because we're more of a closed system that's community owned. Over half of our attendees are from other countries. And that tends to be the most like-minded thinking to how we operate our healthcare system. And it's a super innovative group of people who are there. And so we think about not just how we do it in our payment structure, but how other places can be doing it in theirs.
Thank you. So, thank you.
And Pam.
Yeah, mine was along the same lines, because just how you put the implement in is, by the way, excellent presentation. And I've had the honor of being up there maybe, it's been 10 years. Wonderful program there. And it's great to see how it's evolved. My question is, along the same lines, when you had mentioned Medicare, you went and talked, or excuse me, Medicaid, you had to go talk to them about, because it's really trying to do the right thing, and how do you get the payment to match up doing the right thing. So can you just use that maybe little example of how that was to get that approved? This is really on the payment.
Yeah, I often say, and I hope you don't mind me being too bold in saying this, that we've been successful not because of, but despite the environment of the US healthcare system, right? And so often when you're thinking about a new program design, so we're just launching ACT teams, for example, as an addition to intensive case management. It is so tempting for those conversations to become about regulation and payment, and then that limits what you can do. And what I try to do as a leader is hold that and really allow teams to listen to voice of customer and design things they think would really work. And if I hold like legally an accreditation and how will it be paid up here, and you design something, and maybe that thing is to build a canoe, and that's not, that's literal, like go in the woods and build a canoe with a group of people. Then I'm going to figure out how to explain to accreditation and to Medicaid that that's a behavioral health intervention, and how for that to be paid. And I'm super vocal on that front with our state. We have an 1115 waiver. I was on the benefits design team for that waiver. I think we should be really creative about what we call healthcare and how we pay healthcare. in our states. And I think Alaska Native people have a voice that could be shared for that. And then just one more thing I'll share is that once you figure out a model that you're going to implement, and above that model, we've figured out accreditation and legal and regulatory and payment, then you want the clinicians in that model to deliver care agnostic of who has a payer, so that everybody receives that care and they're not driven in the moment by these really nefarious motivations. And they're just empowered to do the right thing. And in our model, there's no cost barrier for customer owners to receive care. Our outpatient addiction treatment has same day, next day access. We really push for people to be invited in and receive care without barrier. And Medicaid doesn't always pay that. So we've got to figure out how we are going to balance that and fund it, and then just let people do the right thing in the moment.
And Felicia, let's have you ask the last question for April for this session. And then we're transitioning to a group question and discussion, so we can ask questions of anyone and continue the discussion. But Felicia, the floor is yours.
Thanks, Alex. And thank you so much, April, for this. Very, very enlightening. Part of my question is similar to Pam's, but I want to expound on it just a bit. So I'm very intrigued by the notion of CMS and convincing CMS to provide reimbursement for what should be care, as opposed to simply trying to walk within the restrictions of what exists. And I'm wondering if your perception is that CMS is getting more responsive. A colleague of mine was successful in getting CMS to now reimburse Medicare, to reimburse for construction workers. Construction worker who goes into the home of elderly homebound people to fix stairs, to fix the kitchen, to fix the floors and put rails on the staircases, covered by Medicare because of its benefit to health and keeping people at home instead of hospitalized. So I'm just wondering whether we may be in an era where CMS is more open to looking at these types of data and interventions and non-medical care as care. And your thoughts about that?
I think we have drastic not parity in how we pay for medical versus behavioral care. So in behavioral health, we say, we want you to complete a full treatment plan, and we're going to limit the number of services that can be delivered this year. I'd like to see you say to a pediatrician, we're going to limit the number of ear infections you can treat this year, right? And that we want you to submit a service authorization to tell us why there should be a 9th ear infection for this child before we'll reimburse for you to provide that 9th service, right? It just wouldn't be tolerated on the medical side. And somehow that's the way we've created care on the behavioral side, because of lack of trust for behavioral health interventions that we know are cost effective. And we know that our lack of providing them is increasing the acuity of people. I mean, I can make the financial argument for it. And I think that right now, so prior to COVID, I think there was political will to think about addiction services, right? And to do addiction services well. I think now we're seeing, we had a challenging demand for behavioral health pre-COVID. We're seeing a 15% increase during COVID. And I don't think we even know what that demand is right now. And I think there's a climate that understands that at present. And you can say that and people nod and want to think about what the solutions would be. I'm excited about that. My personal experience is more influencing our state's Medicaid plan than it is CMS. And but I do see opportunity in both the Medicare plan, but also in waivers to try new demonstration projects that could prove beneficial in this community or that community and be spread. And I think that's really exciting.
Thank you.
I'd like to jump in with a question for both you, April, and Gretchen, our previous speaker, because each of you has emphasize the importance of building relationships before you try to fix problems, so to speak. And even the model that you showed, April, was trying to allow not just a single pathway to get care, but to allow the care to be there, however was most facile, but also with embedded implications for coordination, recognizing that we are whole beings and we need coordination. So I wondered if Gretchen would first comment about how you prioritize getting the scope of care if you only feel comfortable with one person or another. And from the perspective of someone who's been seeking care, how do you do that? And then have April answer as well. So getting care, even if you haven't been able to build a relationship with everybody on the team. Gretchen first.
Yes, if I understand your question correctly, is how do you prioritize or how do you select getting that trusted care first before we dive into diagnosis and a treatment plan? And I think I don't know so much about the civilian sector and how free you are to pick and choose your providers. I know that I get about 90% of my healthcare through the VA and about 10% through the civilian through TRICARE. So I have a little bit of freedom, I feel like, at the VA. If I am assigned someone who I think is not a good fit for me for whatever reason, and it might not be even that I think that they're not clinically solvent or not, it could just be a feeling that I have. And I just, I know that I'm not going to be able to connect with this person and be able to speak freely. Then I can go through a process and ask for another provider and not that be not in a negative way. Okay, they seem pretty willing to do that. Maybe not quickly, okay, but ultimately it does happen. And I think that needs to be voiced up front. Like, the provider can say, I'm going to provide you with the best care that I can, but if for some reason you're not comfortable with me for whatever reason, by all means, please feel free to say so, and we'll find a good match for you. Because that is the epic center of getting good care, is that very first, that communication and that trust factor, in my opinion.
So I think what I hear you saying, Gretchen, which makes a lot of sense, is letting the patient or customer, as customer owner, as April calls them, have the first choice or right of first refusal, so to speak, to, if I'm misusing that term, but to allow that person to say, no, this is not working for me. I need someone else, but prioritizing the relationship because we recognize that that's the key to a successful intervention and care.
Yeah, I think it goes both ways too. Let's say that I go in and my needs far exceed what the clinician thinks that they can offer, then they should feel free to be able to say, I think I'm not the right person to treat this person. So I think there's freedom on both ends of the stick. Maybe their expertise is not in the area that I need the most, and they know a provider who could maybe have a better shot at it. So I think that it's both ends. On both ends, there should be freedom.
Outstanding. I appreciate that. April, did you want to comment as well?
I will, and I'll just comment briefly. Gretchen, I loved that you anchored that around trust and relationship and finding a connection that makes sense for a person. My two comments are, in addition to relationships between care teams and families, we've worked on communities' relationship and trust with system, that they believe system is going to be responsive to what they need, and they can physically see the ways that they can provide voice. What's been harder is to feedback that to community, to say, we asked, we heard this, we did this with it, did that work? And that being a continual dialogue and conversation between system and community. The other thing I'll say is that, I'm going to give a behavioral health example. In addiction treatment, you generally call and you get put on a wait list. In our system, we want for a clinician to meet with you today and to say, just share with me what you need, what's going on for you, and just listen. And we ask them not to worry about the treatment plan and all the elements of it that Medicaid expects us to do for it to get paid. We just front that and let people just talk and be and build relationship. And that happens much more naturally. And I loved where Gretchen went around that doesn't mean that first person is the right person, but if you trust them and you feel good about it, they can help you get to the right place of care.
Sometimes, it's simple as I'm not sleeping. Okay. And that, what that does to it throws everything off. And so that clinician, maybe they're not my long-term clinician, but they can say, okay, I can help you with this. And in the meantime, we're going to find the right path for you with the right people in there for you. But if we're addressing that one, the reason I came in today is because I'm not sleeping, which makes, adds to difficulty in my life. And, just the fact that that person can and is willing to solve that very first tip of the iceberg, problem, then we can progress. There's already a trust factor then built in because they heard me. I'm not sleeping. And something's being done about it. That is already like huge.
And just to be transparent about where we're at in our agenda, this is great. So we're in the committee questions and comments. So this is exactly what we want. Not just, it can be questions from anyone and discussions on what we're thinking and where we're going. So I want everyone to feel comfortable with that. And there is some time too for our public members to comment. So please, put your comments in the chat and such. And Carlos, you have the floor.
Thank you. I want to thank all presenters, and because I think in part of the challenge, I think we are identifying trust as the glue that is important and relationship being the key piece. But I wonder, April, I imagine that you recruit some people who are not trained in your system, and they are trained in different ways that are not necessarily your ways. And what process do you use to essentially acculturate the new arrivals in what, how, because I think that's a very important part of the process is, you may have very different ways of dealing with things. And if you don't embody that culture, then it becomes very difficult to be effective.
Carlos, you are absolutely spot on. So prior to behavioral health, I worked as the director of HR and a bunch of workforce initiatives, IHI, how do we think about competencies? And so we focused on what are the competencies that prove successful to operate in our model? And then how do we hire people based on their natural alignment with those competencies? So competencies including how you see your role in relationship with others on your team. There's 4. How you see your role in relationship with customer owners. And if you've been in private practice where you set your schedule around when you might want to golf, then you're probably not going to work well in our system because we're going to be designing our system around the needs of our customers. So let's be real about that. And let's talk about what that means. How you work in a system that innovates, how you learn to do it today will change. It'll be different based on the voice of customer. We're going to actually ask you to be a driver of that change. And how you think about your reflection of self as you grow in operating in this system. And we evaluate people based on those 4 things and select them because of their alignment. And let me just use like providers for an example. If you're hired as a provider here, we think you're going to practice differently than you have been trained or have done elsewhere. And so you are going to sit with me for 3 days and think about how story is incorporated into your practice. And then you're going to go to your work site and you're going to have a physician mentor who's going to help you learn how you clinically practice in this model. And most of the time, as an FP, as a primary care provider, when you join a practice, they just give you a room and say, here's your room, practice medicine, right? And for us, we're going to say, it's actually going to take you a year to learn how to be in relationship with customer owners and to operate in this way. And lots of intentionality goes into that onboarding and training process.
And I think that brings up the point that for our work here in the committee, that needs to be a very important part of the deliberation and the planning. Because if we don't have a good way of making that transition from a sort of a physician-centric model to one that is really about listening. I mean, you didn't mention it in your 4, but I wonder, to what extent are they practicing mindfulness? To what extent are they being in the moment? And those are things that are not traditionally trained for many clinicians, at least for physicians. And I think having, but not only physicians, but all members of the staff being able to access that will be important. Because I mean, as I was listening to Gretchen, I mean, that's part of what that program seemed to do for you, was sort of allowing you to come to terms with who you are and then develop the sense of a whole person, and the empowerment that comes from that process. It becomes not only important for the clients, patients, owners, but also for the people who are in the system.
Thank you, Carlos. Sandy, your thought.
Yes. First, I'd like to thank all the participants for excellent presentations. My question is for Gretchen. And Gretchen, I've known you a long time, and you've just touched on just the slightest bit of the amazing work you've done on behalf of our country, and that you continue to do. But as someone who does get 90% of your care in a VA setting, my question specifically for you is, what are the most important things that the VA could do differently to improve a whole person approach to your healthcare?
That's an easy question and a hard question, but I will say this, that it's the gatekeepers, I call them the gatekeepers, and that need to, in my opinion, to be a little bit more empathetic, sympathetic, and a little bit warmer. And, you know, I know they got a lot of things moving, but that's your first point of contact as a veteran when you walk into the VA and you show up for your appointment. And, you know, you're there because there's something wrong and you want help. And that gatekeeper, I call them usually the MSAs, I think, or the whatever they are. Sometimes they're unattentive. You know, an example I'll get is even sitting in the waiting room, they walk out and they'll say, Evans, and I'll stand up and they say, is your husband in the restroom? Okay, that's still happening in 2021. And I can't tell you how awful that feels to a female veteran, okay? And, you know, you think it doesn't happen, but it does all the time. I get letters from the VA, Mr. Evans, okay? That scares me a little bit about my treatment, okay? Because there's some things that I'm thinking. So I think that first connection that you have is so critical. And then it goes to meeting your, the doctor and whatever, you know, clinic that you're in, that rapport is established in the best way possible. Again, that trust factor for veterans, you know how we are. For us, you're either a foe or, you know, you're either a friendly or an enemy troop, okay? There's no middle ground for us. You're either on my side or you're not on my side. And we determine that in probably about 30 seconds. And if we decide you're not on our side, then we're either going to close down, okay, and not give you the information you need to be effective, okay, or we're going to quit coming, or we're going to whatever. But, you know, for us, it's like a 30-second assessment. And that's hard to say, but it's the truth. That's just the way we're wired. You know, is this a safe place or is this not a safe place? And so if we can make the veterans feel safe and feel appreciated a little bit, and that we're not just one more person showing up to get care, I think that would be a great start.
Thank you.
I'd love to add and ask a different question, and that has to do with the fact that we know that so many veterans do not get their care in VA, or get part of their care in VA and part of their care elsewhere. And I would go back again to you, Gretchen, and saying, what are your thoughts about that? Because yes, VA is the largest organized system, but now you've got to interface two systems. What would you suggest is the best way to make that happen?
Okay, so for me, and this is a very complicated question, and it happens to me all the time, because I do get part of my care outside of the VA when it's not the VA's forte. I had very severe skin cancer that required MOA surgery and plastic surgery. Well, the VA, that's not their thing. Okay, so they outsourced me. Well, I knew my own self, and I knew I couldn't walk into that civilian hospital and have them operate on my face without a little bit of help. And so I asked my surgeon, could she have a conversation with my primary care doctor and with my mental health provider so that this process could benefit us all. Okay, what I didn't want to do was, I was going to be awake during the surgery, was freak out during this surgery. Okay, I wanted to be calm, and I wanted her to be able to do what she had to do. All parties were willing, but the initiative was, the onus was, I think, was on me. I don't think that my civilian doctor would have said, hey, you don't need to contact your primary care doctor at the VA. No, not necessarily. So I think we need to encourage our veterans, okay, to say, if you're getting care on the outside and you're concerned about anything, to either ask the VA people to reach out to the civilian, or the civilian to reach out to the VA and ask those questions and get them answered. And you may have to be the person that hooks them up together because you have all the information. But I think that's critical in the care process. It also goes back to the prescribing medications. That civilian doctor, which does not have access to your VA records, and give you a pain medication that could really go cattywampus with what you're already taking, and to the point where it's dangerous. Okay, and you as the person, I mean, I know enough now because I've had it happen to me, to say, no, I can't take that. That's not good with what I'm taking. Can you give me something else? But you get these 22, 23-year-olds, they're going to take they're going to do whatever the doctor tells them to do. And so I think it's important. I think that we need to educate people, so even the civilian doctors, and say, if you are treating a veteran, you might want to ask them if they're on other medications or who their primary care doctor is.
Thank you so much. Seiji, please.
Great, thank you. Amazing day today. And I was trying to get my brain around how do I package this all up, and the words like control, ownership, decision making, autonomy, choice, all those words kind of come together. But it's all, when I think about packaging that up, is it about self-determination and also self-efficacy, right? That you can make a difference and change. Is it about services that are tailored to the community, but then real subpopulations within that community? And I also heard the importance of behavioral health to everything, and I totally agree with that. And within the system, we're looking at the workforce and the teams, not only who's in the team, but how the teams work together. And as a healthcare, primary care, for the underserved person, I'm always thinking about these things, and I agree with them. Some of the challenges I think are similar in the VA and at South Central and other places. It's about cost, allocation of resources. How do you divvy that up? And then getting the appropriate workforce and maintaining workforce wellness. I wonder, April, especially, aside from the cost and the resources and the need for workforce and workforce wellness, what are some other sort of major big buckets of challenges that you face in making this system work?
Thank you. Just a couple of comments I'll make is that people are used to their interactions with healthcare being hard to navigate, difficult, scary, unsatisfying. So rebuilding that trust with healthcare is a biggie. Your comment that people, what are the big things that we also might do? I would say that workforce is a giant challenge that's facing us. So locally, I had conversations with our university about, what is our throughput for students and how are people feeling about the healthcare profession right now during COVID, and what obstacle is that going to create for us as we move forward? I think that we're doing a lot of work right now around the changing demographics of our population, understanding how many elders we'll be serving in the upcoming years. And we have a project that's about aging well, and it targets beginning conversations at age 40 That is my age bracket. So I'm like, why is aging well about 40? Well, it's because it's when we need to start. It's when we need to start understanding what will change in our bodies, but also because we're in that care change place with our parents at that age. We're doing a really big initiative that I think is important that's called New Generations. And it's around the motivation that young parents have to create an environment of wellness to raise their kids. And how do we maximize that motivation by changing the healthcare delivery system from a medical intervention to being a social intervention that supports not only mom, but family, grandparents, and other caregivers in readying their life for bringing that new child in. And that's a gigantic project that we're doing. So I think we've got a lot of cool opportunities to think differently about what healthcare delivery can be.
Thank you so much, April, and thank you for joining us. We know you have to leave, but it's been a pleasure.
May I just say before I jump off, I so appreciate this committee thinking about whole wellness. I love hearing how thoughtful you've been about it. And just specifically, thank you for including the voice of Alaska Native people and their work in healthcare transformation as you think about that work. We appreciate it. I do have a tribal leader meeting next, so I need to spend some time listening, but thank you for having me. Have a great day.
You as well. Thank you so much. Seiji, did you still have a question, or was that the hand just from before?
Sorry, I'll lower my hand.
Okay, great. And I'm going to give Bob some time to ask a question as well. But I also want to make sure we recognize that this is also an opportunity for comments from the public for the next 9 minutes before we close this public session. Please, Bob. Did I lose you?
You're on mute, Bob.
Oh, yeah.
I keep hearing one resounding repeat, and that is communication and education. In order to build a community, there needs to be a mouthpiece, a voice, a means by which we can educate the community and share with the community our story. We don't do that very well in the VA, and we don't do it very well in healthcare. Some commercials are better than others for healthcare, but I think that we really need to have spokespeople out in the communities where we live so that others can understand how we work, and we can listen and hear how they work and find the means by which we can tether our healthcare systems so that they might interact far smoother, and that we can have the transitions without hiccups. I also believe that the safe place is most important, and the only way to do that is deeply care for your people and care for your staff. And I don't want anyone to forget that that balance is a delicate balance, but one which must be achieved for sustainability in whole health wellness.
So true. Thank you so much. Are there questions from the public? I'm looking in the Q&A box. So I want to make sure that we allow, since this is a public session, time for the public.
Ben, it looks like you've said if there's a moment, can you say something? I guess that's the one question I see in the Q&A there. Mark, is there a way to have Ben speak, or does he have to type it in?
I believe he has to type it in.
Ben, if you're able to type something in, we definitely want to hear what you have to say.
I also see the comment from Harold say, and I think he makes a good point. I don't know if you want to verbalize it yourself, Harold, the importance of today of culture and recognizing the differences in culture. April described that culture there. Gretchen described the culture of generational culture, the culture of leadership versus followership culture, the difference between veteran culture and non-veteran culture. There's no question that has to be attentiveness to cultural differences is so important. And hopefully Ben is typing something.
If folks haven't seen it, Ben typed in that he wanted to commend the committee for the focus on the essence of whole health, which is not one service or another, but trust, listening, and partnership. So I'll say that, so that's in the record there.
Great, outstanding.
Thank you, Ben.
Any other comments from committee members while we're waiting for anybody in the public to say something additional?
If I may, I saw a note on chat from Harold regarding the fact that most clinicians outside the VA don't even ask whether people are veterans or not. I think that's a VA sided answer, and I'm concerned about that because we think we do it better than others, but I think there's an assumption even in the VA that at times we don't really worry about our veterans once they're outside the VA. And I think that there needs to be that longer view. And again, hence my words about education. We need to be an education nation and teach, train, and develop those doctors, those who are in residency programs and fellowship programs, in internship programs, but also following up with our local community healthcare systems.
Also, though, there's a point is if you get a referral from the VA, you can to a civilian doctor, you can assume that that person's a veteran. Not rocket science, right? They're being referred from the VA. The VA only treats veterans, and maybe some family members, but there's a 99% chance if you get a referral from the VA that that's a veteran.
Thank you, Gretchen. Ajus, please.
All right, I got to unmute. First, I want to say thank you for having me here today, and this was amazing to hear that I will have a job for the rest of my life when we move into behavioral health as we move forward. But one of the key things I wanted to kind of bring in, I want to ask Chaplain, and he had brought up two different things. One was on the communication piece of stop, look, listen, right? And I think he brought up the whole idea of as a psychotherapist going in, tuning in, right? The whole idea of going present and being able to reflect on yourself before you go in to see a patient, right? So, and in this moment, we're moving that. And I loved how April kind of moved over to change that to customer owner language. So the question I have for him was for moral injury. I know he kind of slowly touched on it, but I was looking at it as being one of the key pillars of what's happening within our current environment, right? And the reason why I'm saying that, there's a lot of different things that's taken place when we're downrange and kind of move on. But the piece away from just PTSD is that moral injury recently has been defined as an impairment or that impairs one's capacity for trust and to elevate despair. So when we talked about the culture, if we are in that place at this moment, that the culture has started to shift and we're moving towards that, how do you see trust being built with that kind of condition in our present day?
I think that a big part of it is boundary maintenance. Since the internal mechanisms that were the mainstay, the folkways, the mores that were our foundation have been shaken and shifted through our experiences downrange. It's more important to have those clear boundaries and, where possible, have supportive structures, whether it be, and we're in an anomic state in our nation right now. Nothing seems stable, nothing seems steady, but where possible, steady the force, steady the field, and help people get links back to home, church, education, organizations, where they can have a sense of belonging and regain their longing to be and become someone as a contributor in our society, to belong and longing to be. In other words, to continue to live and live as best we can. Does that
Thank you. I
answer your
appreciate that.
question?
Yes, it definitely does. I think that moves us to kind of think about it and how we're going to be setting that boundary moving forward. One more question was, I know I talked about the communication piece. One of the key things I know coming from the Navy, I wonder if you've heard of the Patient-Centered Care Communication Initiative, which is PCCI, which is, it was designed to train doctors and staff on how to be present, how to be mindful, how to reflectively listen, and kind of give a change in our patient interviewing that was going on. I think that was something that I experienced while at Walter Reed, and wondering if you had any experience with that.
No, but it was something that was, I participated. I wasn't part of PCCI, but that was the way in which I was trained up to be. Collaborative, communicative, comprehensive in my delivery of care, and compassionate. And that shifted. Part of the training for clinical pastoral education is listening more, talking less. And I think that any initiative like PCCI or patient-centered care really deserves more than lip service. It needs to be practiced. And practice is what we call medicine. We practice medicine. And I believe that we don't always get it right. So again, let's slow things down. Let's try again. Let's pay attention first. Make sure our own house is in order and that we're ready to receive that person. And then after we're in a good place, then we need to go in and care for that person and hear their story. Let me add one other thing. As a board certified chaplain and also as a healthcare executive, I kept my supervisor. In other words, my clinical supervisor. I needed a place that was a vent valve for me, so that when I was carrying the stress and strain of delivering care or companioning people along the journey, I had someone I could turn to. So I didn't have to lay it on Gretchen or any family members or any other fellow staff. I had a supervisor. I think that if we want to coin the term mentor in that sense, maybe for doctors and nurses and other allied healthcare professionals, there needs to be someone you can turn to diffuse, to discern, to decide.
All right, all. On this note, I have to apologize because we are over time for our public session. And I do need to be mindful because our committee needs to rejoin at 2:45 promptly. So I want to thank all of our speakers. This is wonderful and a great note to end on your statements, Captain Evans. Thank you. For the committee members, if you can promptly join back in at 2:45, and the link is in the Zoom invite for everyone. And I think we have heard a lot that is really going to help to inform the discussions and the decisions that we need to make this afternoon and tomorrow. So quickly recharge, get what you need, because we've got a lot of work to do. So thank you all.